From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutoksokan, yung bata ka. Siyempre ikaw, nasasaktan ka, di ba?
Hindi ko na lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos nasa rin ka nila ng bingot, gano'n. Tapos halimaw.
Mga classmate mo, ina-assert mo ako. Ina-assert mo minsan, ina-assert mo ako. Mananalalasert mo ako, tinatawanan mo ako.
Nung baby na po ako nilang parang i-opera po ako. Akala po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and/or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos ako yung makakapuli po kaya po natin.
Ngayon po, nakakangiti na po ako. Natutunan po ng SmileTrain.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with Cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutuksokan, yung bata ka. Siyempre nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos nasaring ka nila ng bingot, gano'n. Tapos halimaw.
Mga classmate mo, inaasar po ako. Inaasar po minsan, inaasar po ako. Mananalalasay po ako, tinatawanan po ako.
Nung baby na po ako nilang parang i-opera po ako. Akala po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos po yung mukha ko po, hindi po kagaya po dati.
Ngayon po, nakakangiti na po ako. Natutunan po ng SmileTrain.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
From the time they are born, children with cleft lip and or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutuksokan, yung bata ka. Siyempre nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos nasaring ka nila ng bingot, gano'n. Tapos halimaw.
Mga classmate mo, inaasar po ako. Inaasar po minsan, inaasar po ako. Mananalalasay po ako, tinatawanan po ako.
Nung baby na po Akala po nilang parang i-opera po ako. Akala po nila parang ano po yung mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. Smile Train is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. Smile Train's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po kasi po, maayos-ayos po yung mukha ko po, hindi po kaya po dati.
Ngayon po nakakangiti na po ako. Natutunan po ng Smile Train.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
Hello. Good day, good afternoon, good evening, or good morning, as the case may be, to all our participants. Welcome to the second day, the last day of our webinar. We regret that many of our participants from yesterday that live in the central Philippines, the Visayas region, may not be able to make it with us because of massive power outages in the region arising from the super typhoon that crossed our central Philippines. But welcome to all those in the provinces not affected by the typhoon. And we are so thankful, as always, to Smile Train for offering to put up this webinar on, I believe, YouTube. And please stay tuned for the announcements as to when the video of our webinar will be uploaded on the YouTube. So welcome again. As we closed the sessions yesterday, we're going to talk more now about problems that may arise when the first line breastfeeding support fails, figuratively or literally. So our first speaker will talk about the so-called second line breastfeeding problems. The next speakers will talk about alternative methods of feeding breast milk, together with what are some of the procedures and processes for human milk banking. And then we will go to another point of care that our patients have come into contact with Smile Train and its partners. And that we're going to talk about the need for relaxation. So could I have the next slide to introduce our faculty for this afternoon? Okay, Dr. Aurora Gloria Libadia has contributed to the content of the lectures of yesterday and also today, but the same personal circumstances prevent her to be with us today. So we'd like to thank Dr. Libadia for her contributions. Next slide, please. Dr. Joanne Gallardo will be our first speaker. Dr. Joanne Gallardo completed her pediatric residency training in the National Children's Hospital here in Metro Manila. Her current positions are as a lactation clinician of the Nurtury Breastfeeding Center. She's also a pediatrician and lactation clinician for Centre Medical International based here in Metro Manila. And she is also a accredited trainer for the Philippine Integrated Management of Acute Malnutrition. She is a diplomate of the Philippine Pediatric Society. Next, Dr. Jessamine Sareno Ang, you met yesterday. She completed her newborn medicine fellowship at the University of the Philippines, our state university here in the Philippines, and its affiliate Philippine General Hospital. Her current positions are as training officer of the Maria Reina Hospital affiliate of the Xavier University Hospital. She is the head of the Human Milk Bank at the Northern Mindanao Medical Center, the largest government center in her region of Northern Mindanao. She is an assistant professor of Xavier University School of Medicine. She is the breastfeeding coordinator for Region 10, Northern Mindanao, and she is also a consultant on human milk banking of the UNICEF Philippines. She is a fellow of the Philippine Society of Newborn Medicine. Next slide. Next, we have Maria Julita Sibayan. She is actually a registered nurse, but she has a PhD. She has a PhD and she is a internationally board certified lactation consultant. She, as on the slide, she is IBCLC accredited. She is also a certified breastfeeding specialist of LER the dash ACNM. She is an Arugaan trained breastfeeding counselor with a lot of community orientation. And her current positions academically are at the Adventist University of the Philippines as assistant professor and as a lactation consultant of their baby ducts, a child health and breastfeeding care specialist clinic. Her affiliations internationally are with IBFAN, ILCA, the Philippine Nurses Association, and STTI. Next slide, please. Okay, so I'd like to turn over to Dr. Joanne Gallardo now. Joanne?
Yes, for our disclosure statement, our mission of promoting and protecting the health of the mother and child diet is in research and policy development. And you can also see our vision is to eliminate preventable causes of deaths of mothers and their children, contributing to all effort to enable their highest attainable state of health. Before I start, all of us, we declare no financial relationships with manufacturers, distributors, or of tobacco products, or even products that violate our milk code. Even if our speakers will show products, we assure you that none of us have vested interest on the products that will be shown. So I would like to start now. Next slide, please. All right. Good afternoon, good morning, good evening to everyone. Welcome to day 2. I would like to thank Smile Train and KMI for inviting me. And of course, I would like also to thank you who are eager to learn more today. I will be lecturing in behalf of my partner, Dr. Libadia, who could not be with us today due to unavoidable circumstances. Next slide, please. We have learned during the first day that the foremost support that we can give a mother who has an infant with or without cleft is nutrition. What better nutrition is there to be offered than the breastfeeding, owing to its many advantages to the mother and the infant, as was discussed yesterday. However, mothers turn to us, health workers, for some guidance, and it is our role to do the following, hopefully, every chance we have with those mothers. First, to build the mother's confidence that she can breastfeed and that she has enough breast milk. Second, to give accurate information to correct misconceptions and answer their questions. Third, to ensure that the mother breastfeeds in a way that helps with milk production. Central to this important step is to observe for good positioning and attachment. We will deal with that later Fourth, to make sure that the mother is supported in other ways. There would be instances, however, that we would have to deal with breastfeeding questions, concerns, or issues other than what was covered yesterday, and we want to be ready for it, hence this lecture. Next slide, please. At the end of this session, the learner will be able to recall good counseling techniques and breastfeeding support, identify and manage common breast problems presented by the mother and baby, and of course, to know when to refer to specialists. Next slide, please. The topics I will present to you today are second line breastfeeding counseling and support actions, which is adapted from the community management of at risk mothers and infants under 6 months of age, or what we call the C Mommy tool, authored by the ENN, GOAL, the London School of Hygiene and Tropical Medicine, Save the Children, and their collaborators. Next slide, please. Most, if not all, breastfeeding problems has a root. Some of it roots from misinformation, a mother's self-doubt, separation of the mother and baby, or sickness. When a mother comes to you for counseling, whether it be from breastfeeding issues or milk supply issues, you will never go wrong if you cover the following general counseling and support actions as discussed extensively in our first line breastfeeding support lecture yesterday. And as a disclaimer, these general counseling and support actions are applicable for mothers of infants with or without oral clefts, even more so for mothers of infants with clefts because they are the most prone to encounter some of these problems owing to the infant's oral defects. Hence, more support needs to be given. Next slide, please. We should learn to praise the mother for choosing to breastfeed and continuing despite setbacks. There's nothing like a good encouragement for the mother to carry on. If at all possible, and for most situations it is, let us keep mother and baby together in skin to skin contact. Now that we are armed with a good amount of knowledge from our breastfeeding experts yesterday, let it be our goal to improve the diet's attachment and positioning. This is applicable for infants with or without clefts. Also, we must also encourage them to breastfeed more frequently and on demand, offering both breasts day and night, 8 to 12 times a day, or in 24 hours. Next slide, please. Every opportunity we get, we observe positioning, attachment, and suckling. Breastfeeding positions can vary among moms and baby dyads, and we can recommend the ones that are most comfortable and most suited to them. After a feed, we tell the moms to allow the baby to come off the breast on her own, or her own, as it signifies that the baby is already full and no longer interested to feed. We also ask about the frequency of breastfeeding. It should be 8 to 12 times in 24 hours because breastfeeding with less frequency may cause a lot of problems, such as what we will tackle later on. We also encourage them to stop any supplements. There should be no water, formula, or other liquids. The nutrients that the infant may get from breastfeeding is enough. Giving them other sources of fluids may cause suboptimal nutrition, or worse, diarrhea and electrolyte imbalance, such as what I have experienced during my clinical days in our hospital. Of course, we encourage them not to stop breastfeeding if needed and could not be avoided because the mother is experiencing too much pain. Well, we tell them to breastfeed first on the side that hurts less. And then when she's ready, breastfeed on the side that is affected. Next slide, please. Okay. When the mother is stressed and in pain, we encourage them to rest and drink more liquids. Stress and dehydration can take a toll in the mother's body and may somehow affect her milk supply. If it is possible, we try to engage her family members to perform other household chores. Another golden rule is to never scissor the breast, as this hold does not offer enough support on the breast. Can you see that? And fingers get in the way of the baby's mouth, leading to a shallow latch. Okay? In the next slide, I will present to you a case with a photograph, and you tell me what you think the mother's breastfeeding problem is. Okay, that slide, okay? All right, so a 23-year-old mother, she's 23, who gave birth 3 days ago, comes to you because she could not make her baby latch. She woke up this morning with heavy breasts that feels hard as a rock and painful to touch. Aside from that, she feels fine. She has no fever. What is the breast problem? Okay, can I count 5, 4, 3, 2, 1? Okay, all right. So, okay, I don't see actually the chat. What do you think? Some of them said it's mastitis. Okay. All right. So next slide, please. Okay, this is breast engorgement. It commonly occurs in both breasts. There could be the presence of swelling. The breasts could be hard, tender, or painful to touch. There can be warmth or slight redness. If you look at the picture on the left, the breast seemed to be shiny. The areola can also be hard and the nipple flattened, which is why the infant may find it difficult to attach. Okay, so engorgement usually occurs on the third to fifth day after birth when milk production increases dramatically and suckling is not yet established. It can also occur when the mother wears restrictive clothing or forgets to breastfeed the baby through the night. So, what can we do with the mother's problem? All right, next slide please. We can instruct the mother to gently stroke breasts to help stimulate milk flow. Okay, and then what I tell the patients is to first use warm compress before she tries to feed or hand express the affected breast. And then after that, um, apply cold compress to relax the swelling. All right. Next is we also encourage them to express milk to relieve the pressure until the infant can attach and suckle. Sometimes it is because the areola is too hard that baby cannot attach. But when you try to express some milk, make the areola a bit softer, then baby will attach. Note, on the first day or two, the infant may only suckle 2 to 3 times, and some of the mothers would say, "Oh, my baby is so good. She wouldn't cry. She will just feed a little and then she's satisfied." But then the third day comes, the baby cries and cries and cries. But this is normal. It's not because the mother has no milk yet. It is just because the baby is more active and more aware of his or her surroundings and his mother's presence. This is still normal. Okay, that way we can encourage our mothers with that. Okay, next slide please. Thank you. All right, so this is the second case. The second mother came to you to say that she wanted to stop breastfeeding as it hurts in the nipple so much. There are no other problems. What you see is a reddish excoriated nipple on those pictures, both of the pictures, that is painful to touch. What do you think is the problem? Okay. All right. Okay, so it is sore nipples. All right. Next. Okay, that slide. Thank you. This can happen anytime after birth, but is most common during the early days while mom and baby are getting the hang of breastfeeding and attachment. As what Dr. Rajesa said yesterday, an improper positioning and attachment causing a shallow latch can result to this. The symptoms are breast or nipple pain. There can be cracks across the top of the nipple or around the base. There can also be occasional bleeding. If the baby's attachment remains to be shallow for a longer time, though, it may start to become infected. Next slide, please. All right. So central to the management of sore or cracked nipple is achieving a proper positioning and attachment. Remember, a baby's mouth should be wide open covering most of the areola at the bottom. Chin should be touching the breast. In order to do this, the baby should be positioned close to the mother. His or her body facing the mother's body. The neck is not twisted and the mouth is facing the breast. Can you see po? All right. Just imagine yourself drinking on a cup of water. Can you imagine yourself drinking on a cup of water? You are facing the cup or the glass. Imagine yourself drinking with your neck twisted. It would be hard. It's the same for the baby. Also, we advise the mother to let the infant come off or detach from the breast after a feed by his or herself, as yanking the baby out after a feed may cause the baby to hang onto the breast and bite. So if the baby is just nibbling and not suckling vigorously anymore, we tell the mom to push the tip of her finger to the corner of the baby's mouth to force it a little bit open. That's when you can remove the baby from the breast. Okay, so that you can avoid damaging the nipples and causing it to be sore. Sometimes, baby becomes impatient when the milk is not yet flowing, causing him or her to bite on the nipple. We can tell the mother to hand express first if the breast is too engorged so that the areola can be softer and start the milk flow before putting the infant to breast. That way, the baby will not bite. Okay, the breast milk itself, okay, has an anti-infective property. So we can tell the mother if there's soreness there, if there's excoriation there, you can actually use the colostrum or the breast milk. You can apply it on the wound and air dry, and it will heal in a few days. Okay, next slide, please. Using feeding bottles may cause the baby to suckle differently from a baby who is directly breastfeeding. Usually, the baby's mouth would be narrower, and then they tend to use just the cheeks to suck the milk out if they're using the feeding bottle, as one would suck on a straw. Suckling this way on the mother's breast can cause pain and sore nipples, which is why we want them to avoid using feeding bottles. Okay, and next, washing the breast, using cream on the nipples before every feeding actually dries the breast. Or worse, it causes damages to the skin. So we also tell them to avoid doing it. Bathing once or twice a day is enough. Aside from that, putting any other scents on the breast can actually cover the natural oil and scent produced by the Montgomery glands of the breast. You know, the scent produced by the glands actually makes the baby interested to suckle. So if you cover it with another scent, the baby may refuse breastfeeding because of this. All right. Next, do not wait until, I'm sorry, can we go back? Do not wait until the breasts are full before breastfeeding because it will cause engorgement and difficulty for the baby to attach. When this happens, tell the mother to gently hand express first to soften the areola before letting the baby attach to the breast. And if in case the sore area appears to be infected or large, we may need to refer to a lactation consultant. Next slide, please. All right. Okay, next slide, please. Okay, so the next case, a young mother came to you due to a tender lump that she could feel inside her breast, which she noticed when she started pumping. She also said that her milk was not flowing quite well. She otherwise feels fine with no fever at all. What do you think is the breast problem? Okay, I see mastitis. All right, all of them. Okay. Three of them mastitis. Okay, so next slide, please. Actually, okay, I have another one. This one is another picture. Okay, another mother came to you due to high fever, feeling tired and a warm, tender right breast. Okay, when you inspect, you can see at the picture, you see a diffuse reddish area on the breast. When it is touched, you feel a wedge-shaped tender mass inside. and the baby also refuses to feed on that breast, what is the breast problem? So those two are different cases, okay? The first one and the second one are two different cases. Anyone wants to guess which one it is on the second case? Okay, they're quiet. Okay, so let's next slide, please. All right, let's differentiate the two. Okay, so the first case, the first picture that I showed you a while ago are actually plug ducts. Okay, they manifest as lumps that are tender with some localized tenderness. The mother should generally feel well with no fever. On the other side naman, on the other picture, is actually mastitis. It is caused by an infection. It is usually a complication of a plug duct that was not removed, which allowed bacteria to seep in. It causes severe breast pain and swelling. A wedge-shaped but undefined mass can also be felt inside the breast. Due to the infection, the mother will generally not feel well and have fever. Sometimes, but not all the time, the infant may refuse to feed from the affected breast as the milk tastes more salty. A common cause of both of these conditions, however, is improper milk drainage or improper milk removal, to say the least. It usually occurs when mom decreases the frequency of breastfeeding, introduces a bottle, slept overnight with restrictive clothing, or using breast pumps. In fact, 8 out of 10 of my patients who came to me for plug ducts and mastitis were all using breast pumps. Why? The sucking mechanism of the pump may suck a plug duct forward, but it gets stuck. Imagine sucking a pearl out of your straw when drinking milk tea, which is why the ducts get plugged. For mastitis, the repeated friction, on the other hand, between the flange and the breast, okay, the repeated friction causes for the good bacteria to be stripped out and they give the bad bacteria an opportunity to seep in from the skin, which is why it happens. Okay, while it may not happen frequently, it's still a possibility, even if mothers try to clean the pump after each use, which is why we also tell the mothers if you can avoid using breast pumps, may it be manual or electric breast pumps. And it's important that you watch later because our esteemed doctors will talk about hand expression. Next slide. Central to the management of both is to relax the mom and soften the breast. This can be achieved by applying warm compress or taking a warm shower before hand expressing or breastfeeding. When breastfeeding, tell the mother to use different positions so that infant's tongue or chin is close to the side of the plug ducts or the mastitis side. The positive pressure inside the mouth and the vacuum generation of the suckling causes the plug ducts to be removed and milk drainage to become more efficient. Mothers can also apply gentle pressure to the breast, okay, using the flat of the hand, rolling the fingers towards the nipple, okay, and then they can also express the milk or let the infant feed every 2 to 3 hours, day and night, until it is relieved. Next slide. If after all these steps are done, however, and no improvement is noted in 24 hours, referral to a physician should be made. Remember, tell the mother not to do the scissor hold. This is the scissor hold. This is what we usually see the moms doing, okay, when holding the breast, as it does not support the breast well and will get in the way of the baby's mouth and proper attachment. Next slide, please. The thing with mastitis is the mother is in a lot of pain plus the flu-like symptoms. However, it is very important to still drain the breast. Okay. Next. Okay. Okay, next slide, please. Oh, no, that's okay. Sorry, can you do the previous one? I'm sorry, I got confused. Okay. Nothing or no one else can drain the breast better than the baby through direct breastfeeding, which is why we still encourage the mother to feed on the affected breast. However, if it is too painful to suckle, instruct the mother to hand express. Expressed breast milk may then be given to the infant. Referral is also needed as the mother may need to take antibiotics and pain medications. She also needs a lot of rest in bed and plenty of fluids. Next slide, please. All right, last, as I think this is the last, or maybe second to the last case. Mother says there is no more fever, but that area on the breast is itchy and painful to touch. You can see that round discoloration of the breast skin. Under it is a discrete, tender, round lump that may vary in softness from rubbery to fluctuant. What do you think is the breast problem? Okay, I'm looking at the chat. All right. Wow, Miss Lisley, Miss Ladale answered. Do you have an answer for this? Okay. No answer? Okay. All right. Time's up. Next slide. Actually, this is a breast abscess. A breast abscess is a collection of pus in the breast and is a complication of mastitis. There is a thin line in the continuum of engorgement, mastitis, and abscess that immediate treatment is needed to mitigate them. Sometimes at the height of a patient's symptoms, it is hard to tell mastitis and abscess apart, except that the palpable mass in the abscess tends to be more localized and defined, such as the picture presented on your left. Despite taking antibiotics, however, the abscess may still develop or get bigger. This is why a follow-up with their physicians and or breastfeeding clinicians are needed in this case. When a considerable size abscess indeed develop, despite antibiotic use, we need to refer to a physician who can order an ultrasound and drain the abscess. A more conservative method of draining it is through needle aspiration. It is less invasive, more cosmetic, and decreases the risk of developing fistulas. Fistulas are milk that's going out from the breast skin. So as compared to the usual incision and drainage, the needle aspiration is safer, okay, in the interest of our mothers. Moreover, incision and drainage can also damage breast milk ducts and result in decrease in milk supply. So it is important that more doctors consider needle aspiration first. Next slide. After surgical drainage, if needed, breastfeeding on the affected breast should continue, even if there is a drain present, with the provision that the infant's mouth does not come into direct contact with the purulent drainage or infected tissue. Okay, especially when the baby's mouth has wounds inside them. So the pus can go directly to them. But if the parents are actually worried that there's pus in the milk, when the baby is actually breastfeeding exclusively, there's a protective lining in their gut that protects them from that. So it is safe. This is also according to the Academy of Breastfeeding Protocol in number 4, which is abscess and mastitis. You can see in this picture, thank you, Dr. Sibayan, for this picture, that the baby is still breastfeeding on the affected side, as the baby is more adept in removing or draining the breast well, better than any hand expression or breast pump that you can use. Next slide, please. Okay, so this picture may speak for itself. I will not ask anymore. This is a flat nipple. Okay, so every mother has a unique nipple shape. However, mothers who have flat, inverted, large, or long nipples may express that breastfeeding to them is challenging. Okay, another picture on the left shows an inverted nipple. In general, first, how do we acknowledge them and counsel them? First, we'll listen to the mother's concerns. Even if you think that their nipple is not too different from the others, we still need to validate what they feel. We give extra help with attachment. We ensure that as the mother is putting infant on her breast, she or her breast gently touches the infant's lips, okay, to encourage him to open his mouth widely. And the mother aims the infant's lower lip, well below her nipple, okay, so that the nipples goes to the top of the infant's mouth and the infant's chin touches the breast. Okay, I hope you're appreciating what I'm doing. I'm doing this. For example, I'm the baby. Okay, we anchor the chin towards the breast tissue so that when the baby opens his or her mouth, there will be a deeper latch. Okay, next slide, please. For long nipples, okay, all right. Okay, for long nipples, we place the infant in a semi-sitting position to breastfeed. This allows the infant to tip his or her head back a little in order to avoid triggering the gag reflex. For what seems to be inverted nipples, okay, we can try to do the pinch test first. All right. Okay, we can encourage also the mother to try different breastfeeding positions, lying down, the underarm position, or lying or leaning forward. Okay, and then when it takes a longer time to learn the best position and the baby absolutely refuses to feed, we tell the mother in the meantime to express her milk at least 8 times a day and cup feed expressed breast milk. Hand expression and cup feeding will be discussed more later on the next lecture. Next slide, please. Okay, so it is important also that we tell the mom and we counsel them. We keep on trying. Be patient. Most babies want to suckle and will find out how to open their mouths wide enough to take the nipple eventually. Although it may take a week or two or multiple visits with you, but it is worth it. Next slide. Okay, so for mothers with inverted nipple, okay, so there's a thing as pseudo inversion and real inversion. Before we discuss the inverted syringe method, I mentioned earlier to try to do the pinch test. If you can see this breast, it seems like this breast has inverted nipples, correct? Okay, so the pinch test is like this. Okay, I'll allow the view to be side on your side. Okay, for example, my hand behind the breast is the chest wall. So we're gonna use our 2 fingers, about 2 centimeters, all right, from the nipple base, and then we will try to push. We will try to press the areola towards the chest wall, and then we try to compress it, moving forward as you would do a toothpaste, and then and you might need to do it many times, okay, and then there voila, the nipple everted. Okay, so this is what I find most of the time with mothers. They only have pseudo inversion. Okay, so you can tell them that if you allow the baby to latch and latch and latch, the baby might even evert your nipple on its own. Okay. However, if the breast is still inverted and the nipple is still puckered, even if you try to do the pinch test, or if you ask the mother, is your breast like that even before you give birth? Well, then maybe this is real inversion of the nipple. So for these moms who really find it extremely difficult to let the baby attach, we demonstrate to them this effective inverted syringe method. So we're going to use 20 ml plastic syringe to pull out an inverted nipple as follows. Okay, so we cut off the adapter end, if you see that. And when we cut that off, the end is rugged, right? And it's sharp, which is why we pull the plunger out and we move it. We pull the plunger out and we move it on the smooth end of the syringe. Of course, the smoother end of the syringe also has a bigger hole, so it will accommodate the nipple most likely. Okay, so and then for example, I have the inverted syringe with me. I put it on the breast. Okay, before I pull the plunger out, I will first press the breast or the areola towards the chest wall so that it will not be too painful to pull the nipple out. Okay, so this will stretch out the nipple. Okay, We do this for 30 seconds to make the nipple stand out just before each latch on. But to tell you the truth, I really don't use this too much with most of my patients. Okay, next slide. All right, so another concern that a mother may come to you for is not enough breast milk. It is important that we do not just dismiss her concerns, telling her outright that she is imagining things. Next slide. Of course, we'll listen to her concerns and look for signs and symptoms that this might be real, not enough milk production. So what are the signs and symptoms? First, a baby that's still passing black stools on day 4 or even more than that. Or those at day 6 or more has less than 6 wets or urine output per day after the first week. Another one is not taking good deep suckles followed by a visible or even an audible swallow. Okay, if the baby just keeps on nibbling, okay, so it might be no that she's not taking in enough. Or for example, the breastfeeding is very frequent. Well, the normal frequency of breastfeeding is about 15 minutes to 30 minutes. Sometimes it really depends on the temperament of the baby. But if the breastfeeding is 45 minutes to 1 hour or 2 hours on end, and it's every feeding, and the baby doesn't look that it's getting some weight, well, there must be something, no? And if the baby cries often after feeds, or on the other hand, maybe the baby's just not interested in breastfeeding, so there must be a problem. Another one is if the stools are small, hard, dry, or green and infrequent. And of course, for those who have weighing scales, if you can see poor weight gain, or if you compare them to the CDC Z-score growth chart, no, if it's flat or slopes downward, or the weight gain is less than 50 grams per month, well, we might need to consider that there are some issues causing real not enough production. Next slide. If we see one or more of those that was mentioned, we need to spend more time to observe attachment and suckling. We ask about the frequency of breastfeeds, which must be 8 to 12 times in 24 hours. We still remind them to stop any supplements, no water, other drinks, or foods. Okay, some babies receive coffee, some babies receive dairy creamer. All right, but we tell them to stop that. We look for illnesses or physical abnormalities either with the infant or with the mother, and we also look for bonding or rejection. Next slide. If none of the signs and symptoms point to real not enough milk, we gently explain what the difficulty may be. Can be growth spurts. It usually happens around 3 weeks, 6 weeks, or 3 months. Actually, with some studies, growth spurt doesn't necessarily mean that they grow really very, very fast, but it's just that it's a mechanism for the babies. They tend to want to always cuddle the baby, they tend to want to always breastfeed from the mother. It's because it's a mechanism for them to increase the breast milk of their mother, and these are called growth spurts. Another one is cluster feeds. So these are feeds that are bunched closely together during certain times of the day. For example, the baby tends to breastfeed hourly in the day and then sleep in the middle of the night, only to wake up in the early hours of the morning and breastfeed again. These are cluster feeds, and these are normal. So if the baby seems to be not taking on weight though, however, and if we have a capacity to do so, we explain to the mother and that they will be seen daily until the infant begins to gain weight. So it may take 3 to 7 days for the infant to gain weight. Next slide. We then build the mother's confidence if it's not real enough breast milk. So it's just perceived. So we reassure her that she can produce enough milk. We do it gently. We don't tell the mom, "Oh, you're imagining things. It's not real enough production." No. We do it gently. We validate their feelings and we counsel them right. Okay, we explain and we say this over and over again. The more the infant suckles and removes the milk from your breast, mommy, the more milk you will produce. All right, next slide. Okay, so we also let the infant come off the first breast by him or herself before the mother offers the second breast. Okay, and of course, we need to tell them, let's avoid separation. We keep as much as possible the mother and the infant together, skin to skin. Okay, and also we need to ensure we might be just looking at the baby, but we are not looking after the interest of the mother. We make sure that the mother gets enough to eat and drink. Okay, so note, if there's no improvement in the weight gain after 7 days is achieved, we can refer the mother and the infant for supplementary suckling to inpatient care. Next slide. To reiterate, when a mother comes to you with perceived low milk supply or the mother only thinks so, we search for signs and symptoms of real not enough breast milk. We still do it. Okay, our counseling and support actions also point to listening to the mother's concerns and why she thinks she does not have enough milk. If applicable, we can also check the infant's weight, the urine, and the stool output. So if the weight gain is still poor, we need to refer. And of course, the application of the counseling and actions are the same as for the real not enough breast milk. Next slide. So we are done with the second line breastfeeding counseling and support actions. Next slide. It is important for us to never turn our backs or dismiss the mothers, especially when it comes to feeding concerns, whether their infants have oral clefts or not. In order to ensure a healthier mother and baby pair or baby mother and baby dyad, we give services specific for the mother, such as nutrition practices, health services, care practices, water, sanitation, and hygiene practices, and proper health education and information. I hope you've learned a lot in this first lecture. With that, I turn you over to our esteemed speaker, Drs. Maria Julita Sibayan and Drs. Jessamine Sereno, to discuss with you the alternative methods of feeding breast milk. We start with Dr. Marge. Take it away, Doc Marge.
Thank you, Doc Joanne. Are we not gonna have the question and answer portion for your part first?
No, we will have our question and answer right after your lecture, Dr. Marge and Dr. Jessa.
So
Please scribble your questions and be ready and put them in the Q&A.
Doc Joanne will be more than happy to answer these questions later.
Okay. Thank you.
Thank you very much, Doc Joanne, for discussing to us, the many challenges a breastfeeding mom can encounter. Now, she mentioned in her lecture that it's also important that while moms are being treated for whatever breast issues they may have, parents should also be taught alternative methods of feeding breast milk that will come in handy, okay, for these families. Next slide, please. Our objectives for this session are the following. We would want the attendees to be able to describe how to properly perform hand expression, discuss alternative feeding methods that supports breastfeeding and cleft care, discuss basic principles of human milk storage, discuss the basics of human milk banking and its benefits to the infant mother dyads and the communities, especially during times of disasters and emergencies. Next slide, please. So earlier we talked about hand expression. It is a very simple skill that if parents learn would really serve them for a long time. I myself, as a breastfeeding mom who had to work while nursing my little one, found how valuable hand expression is. It saved me a lot of stress. I was able to collect milk when I am separated from my infant, so that when I come home, I have a stash of milk which will be given to her when I go back to work. Hand expression is a skill that allows the mother to effectively empty her breast. It allows her to collect her breast milk when baby is unable to breastfeed, and it is very useful in the context of cleft care. Now, hand expression often is not given much attention in an era where everything is made easy by the conveniences of contraptions. But according to research by Fisherman in 2011, early hand expression led to 96% success rates in breastfeeding mothers at 2 months postpartum compared to pumping that only averaged around 72%. And this can be related to the fact that early pumping more so causes engorgement, making it difficult for the infant to suckle. Because of the breast being so hard, you cannot get that areola into the mouth, allowing the moms to become more frustrated with the breastfeeding experience, making them feel, feel they are not able to nurture their child and they end up bottle feeding. So it is really important that we emphasize how hand expression can be a very useful a skill to learn for mothers, especially in the Philippine context where buying pumps become at a price, something that many moms in our country, especially in the rural areas, will not have access to. Next slide, please. So here, I have a breast model here. I hope you can see mine. With the background, it can be challenging. I think it's very important to note that to do or to perform hand expression, you have to know the proper placement. Of course, as always, we emphasize the importance of hand hygiene. We always tell our moms to hand wash just before you collect your breast milk. You can either alcoholize when you're out, okay, you're on the go, and you would want to position your fingers behind the areola. Oftentimes, moms feel they do not have milk because when they try to express breast milk, they put their fingers in the wrong position. I find that placing the fingers in this position, such as in the one you see in the picture and the one you see in my screen, is similar to a deep latch where the baby is able to get much of the milk. If you just try to press the tip or the nipple, you see very little milk coming out, and that is similar to a shallow latch. So you see in this picture, you want to position the fingers, that is the thumb and the pointer finger, and sometimes even the middle finger, okay, opposite the thumb in alignment with the nipple. Okay, you ask the mom or you instruct the mom to pull back towards the chest with the hands open like so. Okay, like a letter C or a letter U or a letter C, with the hands relaxed, placed appropriately in that landmark. And then after pressing the fingers back towards the chest, we tell them to compress the fingers together. Okay, and then we ask them to repeat this, okay, find the rhythm. I have a video of a mom doing hand expression. Can you please press the video? So first, guide the mom. So with there, okay. Teach the mom to put the finger in the right position and then press. See? You notice that there is no kneading done. Mom is basically just putting the two fingers together and you would see milk squirt out. At first, it may not be like this. It might just appear as drops or trickles. But when the mom starts to develop milk ejection reflex, you would see that the milk will squirt out, such as in the video seen. Okay, next slide, please. Okay, so I think we missed one. Can we go back? There. A mom has to be taught that you have to do this for about 5 to 7 minutes, and then you would have to move to another position. You see in the picture on your screens, we have two positions there. The hand placed on the 3 o'clock and 9 o'clock position, and then you have the fingers placed on the 12 o'clock and 6 o'clock position. Okay, so they might have to do it first at the 3 o'clock, 9 o'clock position, perform it with the rhythm until milk starts to flow out. And when the flow slows down, they might have to transfer their hand to another position, that is the 6 o'clock and the 12 o'clock position, and do it again. So it may take about 20 to 30 minutes for mom to fully express her breast milk. And the good thing about this, it's about the same time it would take you when you're using your electric pump. So it's not really, others would say it's more convenient to use the pump, but in reality, you use the same amount of time for both with less of a hassle, because you just need to wash your hands. You just need to pack away your milk and put it in an insulated bag so you can transport it back home, minus the need for aftercare for the pump parts, the extra chore that is needed to maintain your pump, time that you can very well use to cuddle and, spend time with your little one. Next slide, please. Now, on the screen, you see the many alternative feeding equipments that can be used to feed the baby who isn't able to breastfeed. You may, as what Doc Gallardo mentioned a while ago, why you see certain products in this lecture, we do not have any vested interest in any of them. Okay, and they are only cited for the purpose of education. Now, in cases when breast milk, when baby isn't able to successfully latch just as yet, whether cleft or non-cleft, we can use the following equipments. From the top left, you see a nifty cup. I will discuss this later. A variant of which is a cup in the middle. The three topmost photos point to a cup which you can use, but you can always use the available cup at home. Okay, and down below you see a supplemental nursing system, the one using an OGT. Usually we use French 8, French 7, attached to a syringe. You have a spoon, and then you have a dropper or a syringe, which can also be used to feed the child. Notice that the following equipment were chosen primarily because it is breastfeeding supportive and that it minimizes the likelihood of nipple confusion. It is also, the use of these contraptions is also supportive of the development of the orofacial musculature, the muscles that will be used later for mastication when the child starts complementary feeding. But what I personally love about this alternative methods as a clinician is that it also is supportive of post-operative care, especially for babies who have had their cleft lip and palate repaired recently. Unlike the typical bottle or the special feeder like the Haberman, which is very pricey, not as accessible, it does not apply pressure on the sites where the suture was done during the repair. Okay. In fact, surgeons would often tell the moms not to feed with a bottle at the time after the surgery. And so teaching families, mothers with special children who have cleft, okay, would need to learn how to use this alternative feeding methods so that after the surgery, they will not have difficulty feeding. Although it was previously discussed yesterday that often babies do not have a problem with taking the breast right after surgery for as long as they get clearance from their surgeons that the child can already start feeding. Okay. It is also important to note that when using a dropper, we don't want to insert the dropper deep into the mouth. We will show you pictures later because we don't want infants. Okay. If you look at all these feeders, except for the dropper, babies might have a tendency to purse their lips to suckle onto the dropper, which you will not see in the previous ones because we maintain the wide open mouth of the baby, which is more supportive of the actual latch, which requires the baby to have a wide open mouth to get a mouthful of breast when feeding. Okay? So later on, Doc Jessa, my partner, will also be showing to you how to use the nursing supplemental system here, the one with the syringe, okay, in the next slides. Next slide, please. Okay, so here we have cup feeding. Okay, this is a safe alternative to bottle feeding, and many hospitals right now, especially the mother baby friendly hospitals, do not use artificial bottles and teats, artificial teats and bottles in their hospitals, and instead would use cup feeding. Okay, we usually use this to feed the infant expressed breast milk, and it is shown that it minimizes the likelihood, or it does not result in nipple confusion. And as I have mentioned, together with hand expression, this one is associated with better breastfeeding success. By the way, let me go back. I just remembered teaching the moms to do hand expression, especially for when they are separated with the child. Early hand expression will allow them to stimulate and trigger the milk flow and the milk production, which, by the way, has begun when they were 16 weeks pregnant. Okay, most of the time as a clinician, I'm sure Doc Gallardo and Doc Jessa will chime in on this. Most of the time, moms would say, I do not have milk, I just gave birth, I do not have milk. But they just need to be taught how to hand express and collect colostrum and give it to their little ones, either through a dropper or through a cup feeder, such as in this photo. Okay. So we saw that babies who were cup fed showed better breastfeeding outcomes later on, because they do not develop nipple or flow confusion, which gets in the way of breastfeeding. Okay. Some might ask, why don't we discuss bottle feeding? Well, there are many things that we have to consider when we talk about bottle feeding. Unlike the ones that I have shown, okay, in the previous slide, this feeding method allows the child to pace the feed, which is similar to breastfeeding, where the child is, or the infant is, in control of how much milk they take, which sadly do not happen for bottle feeding, which is more flow dependent based on gravity. Next slide, please. So how do we properly cup feed the infant? First, of course, we would want to start with hand hygiene. We wash our hands, not the nipples. Okay, we would want to prepare the cup and fill that to no more than 30 ml capacity, and we do not fill it to the brim. You would want to support the infant in an upright position, making sure, of course, that the infant is alert and awake. Okay, and with his back supported and elevated, with the mom holding the baby. Okay, so you see in this picture, it's the grandmother of one of our patients who is performing cup feeding. Of course, there's a slight learning curve to this. Okay, there might be some spillage at first. Do also note that it's not the one feeding who pours the milk into the mouth. We do not feed, we do not trickle the milk onto the baby's mouth, but instead allow the baby to lap. Okay, next slide, please. Okay, if the baby feels the tip of the milk touching their lips, that's the time they lap and slowly pace and take milk. Okay, with each swallow, they will take milk. You would know that they have had their fill already when they start returning or pushing the glass, or they return the milk which they have taken back into the cup. Next slide, please. Okay, so again, it's important to maintain the position until the baby laps using his tongue and feeds and swallow. This movement actually supports the same movement for when the child starts to chew the food. So it's an exercise sort of that prepares them for when they start feeding. Okay, so of course you would want to wash the cup, okay, in a hot soapy water after you use it. Okay, and we find that infants, okay, who learn cup feeding early on also tend to be more independent when they start feeding on their own, because they learn cup feeding quite early. Next slide, please. By the way, this picture is credited to Dr. Pinky Imperial. Yeah, featuring her baby. Now, I want you to look at this next video, and we'd like to credit Dr. Mian, okay, for this video. Okay. This is an infant who was transferred to the care of Dr. Mian Silvestre. And as you can see, the child in this picture has Pierre-Robin sequence. And you would obviously notice the micrognathia, or the small lower jaw, okay, the receded chin. But if you look closely inside, which we cannot see in this video, the child has complete cleft palate. Okay, so most of the time, babies who have this would have breathing problems. Okay, they would have feeding difficulties, and because of inability to feed as well as their other infant counterparts, they might have slow weight gain. Now, in this video, you see the baby is going to be cup fed for the first time. Can you please play the video? Okay, see? The baby had no difficulty whatsoever. Sometimes when the baby is very young, we swaddle them so that they will not move about when we try to feed them. But in this video, I think the swaddle wasn't needed because the baby was a champ. Okay, baby was more than happy to drink milk and take milk from the cup without any problems. Okay, of course, when we cup feed, we also have to take time to burp, okay, the child, and keep the child in an upright position because we would want to avoid aspiration. There you go. Next slide, please. Okay, another thing that we use, okay, to feed infants would be using the Nifty Cup. This is a product by Lerdal, okay, and this is actually similar to the Paladai feeder, which is used in India, a feeder which is similar. It has a spout, okay, which allows babies with cleft to feed. Okay, so this is similar to the Paladai feeder. And in this video, you see one of our Smile Train babies. From yesterday, you saw her. Baby C hails from Lukban, Quezon. Okay, the mom, although she breastfed previously, okay, she has a difficulty with feeding this little one. Okay, at the time of the consult, her baby was already 3 months old. Okay, and this baby has a complete unilateral cleft lip. I showed, when they came to the clinic, I showed them how it is done. The daddy was very excited to see how the baby was able to drink from the Nifty Cup, and then they sent me this video at home when they reached home. See? So the mommy was taught to hand express her milk because she had milk, because it was her third or second child. So it's not really difficult for them it's not difficult for mommy to have milk because she has it already. Okay? The challenge for them was how to feed. At first, they thought they needed to mix feed, but they found out later on that it was not needed. Okay, thank you. Next slide, please. Okay, another method of feeding is through the use of a syringe or dropper. In this photo, in this video rather, I have a child and I had to use, this baby has a cleft palate. Okay, although it was easy supposedly for them to nurse because the lip there is a seal on the lip when baby suckles, it's still a challenge for them. And so we had to teach the mom, as anticipatory guidance, we have to offer them alternative means to feed the child. And this time we use the syringe or the dropper. So as always, we start with hand hygiene. Okay, we would want to prepare the dropper and the cup of milk ready. And of course, similar to cup feeding, we have to ensure that the infant is in an upright position with the back supported. The child should be awake and alert. Okay, we would want to secure the hands and then slowly drop the milk into the baby's mouth, not inserting the entire dropper or the syringe inside because we don't want the baby to have a purse lip. Can you play the video, please? There. And of course, at first, we have to tell the parents when we teach them alternative feeding methods, there is a learning curve. And I could not emphasize this more, okay? That's why we need to tell them that it takes a lot of a practice, okay? They need to be patient with their ability to learn it and also patient with their child, because once they get it right, it's going to be easy peasy. It's going to be like a normal thing already. Okay? So they do not fear that their child is becoming hungry because they were not able to breastfeed, because that's the common concern we see among moms when they see us. They are afraid that their child is getting hungry because of them trying to learn how to breastfeed. So to mitigate the fear of not feeding the child, we have to give them alternatives to feed the child just as they try to breastfeed their little ones. Next slide, please. Okay. The next method of feeding is something that we find most useful, especially during times of disasters and emergencies. As they say, it takes a village to raise a child, a community to bring back smiles. In this photo, credits to Doc Mian, this is a mother who volunteered to nurse a breastfeeding infant who was orphaned in a typhoon in Tacloban City. Okay, of course, with us delivering, so what happens is the mom would come in and nurse this infant, okay? Especially if the child, for some reason, okay, is separated from her mother, okay? However, it is also important to take note, okay, that with safe quality care comes culturally sensitive and inclusive care. And we want to be able to contextualize the use of these methods, especially wet nursing and cross nursing, which I'll be discussing in the next slide. We would want this to be contextualized based or befitting the location or the setup of the person or the counselor who is teaching the breastfeeding diet. Okay, we would want you to be able to learn from our sharing and learn to adapt and contextualize it, these interventions to where you are. Okay, there are many variances between countries, and there might be respective guidelines which is acceptable in your location. An example of which would be milk sharing for our Muslim counterparts, because there's milk kinship among Muslims, wherein if I breastfeed the baby of another mother, by virtue of the milk sharing, her baby also becomes an extension of myself. So they cannot be thrown later on, they cannot marry because they become milk siblings. Okay, so we have to be able to fashion our interventions based on our locale. However, such as in our Muslim counterparts, there's what you call a fatwa, a religious edict issued by local religious leaders for our Muslim brothers and sisters, which says that they may be allowed to do milk sharing because breast milk saves lives. Okay, of course, there are select situations or conditions where this is allowed, but my strong point here is that we just want to know, okay, the cultural practices, the cultural norm, and what is acceptable, so that we can fashion our interventions befitting the population we're trying to help. Next slide, please. Okay. I remember back in the day, royal families, kings and queens would have wet nurses. So I guess now in the modern times, this is still something that we do in communities. And I think it is important to note the value of mother support groups in these two methods of feeding, the wet nursing and the cross nursing. Because if you have a very strong mother support group, okay, you have a group of moms, 4 moms, who help out each other, or you have a community, okay, it's relatively easier to be able to do this and adapt it to your care. Okay, so in this next photo, this is one of the patients that we have attended to. While this is not a cleft baby, the baby on the left is actually a bit older than the one on the right, the one wearing the white shirt. The mom had legitimate supply problems, but we wanted, okay, the mom wanted her child to be breastfed. And so we set up these two moms who happen to be in the same community where I come from. I currently support Advent Moms, a local support, a breastfeeding motherhood support group in my area. And these two moms, I was able to patch up. So what happened was there was a reciprocal agreement. The moms bonded for 2 weeks. Okay, the mom with the better production nursed the small baby, and the better sucking infant nursed on the mom with supply problems to help her supply as well. And within a few weeks, we saw the child gain and they became friends. And this is the first birthday of the baby on the left, who is now the one wearing the red jumper suit. Okay, so this would require, a very strong community, and this is what we have been driving since day one. It's not just the community of support, the multidisciplinary involvement is not only limited from feeding and nutrition down to rehabilitation. This also involves the community, and that's why we're very blessed here in the Philippines, because we have mother support groups who work together with us to allow us to meet these goals. Next slide, please. Okay, now this is another variant, and the picture is credited to Dr. Silvestre and Dr. Alfonso. You see here another type of cross nursing where the mother on the left, okay, the mother B, has expressed her milk and is offering to drip drop the milk that she has collected for the mom who is nursing her infant. Okay, mom A has very little milk, but we know and we have discussed that the suckling of the infant is a very good stimulus for milk production, and we want baby to suckle more because the more baby breastfeeds, the more milk the mother makes. But sometimes they tend to get tired or they get impatient because of the lack of milk, and this is mitigated by dropping some of the milk mom A has, okay, over onto the baby who is nursing with mother A. This technique will be further discussed by my partner, okay, Dr. Jessa Sereno, and I will turn you over to Doc Jessa.
Okay, so thank you, Marge, for a very excellent lecture. So can we have one slide back? One slide back. I think Marge missed the last slide.
Yes.
Can we have the last slide? Okay, so this if you can see this last slide, this mother B who has her express milk drip dropping. Second slide, please. Next slide, please. Okay, if you can see mother B drip drops her express breast milk to the baby of mother A. So what is this drip drop? No? So I'm gonna introduce the drop and drip technique. So as what Marge said, this can help augment the volume of milk that the baby is getting from her mother as the mother is trying to build up her supply. So this drop and drip technique is a technique to increase the milk supply. And I'm gonna discuss this because this last two alternative methods of feeding that I'm gonna show you are being used during relactation. And if we all know, this can be very relevant also in trying to bring back some of our cleft babies to the breast. And we sometimes receive the cleft infants already experiencing bottle fed before it was referred to us. So there's the challenge to relactate the mother who were not stimulated at birth because they were called off that they cannot breastfeed totally. They were not given a chance to initiate breastfeeding. And at the same time, the baby experience already bottle feeding. So this drop and drip technique is a technique to really increase the milk supply and also encourage or entice back the baby to the breast. So what do we do here? The baby is latched on the mother's breast, and this additional milk coming from either a spoon, a nipple, a syringe, or a cup is being trickled from to the breast, or at the top of the breast, and it provides infant with a steady flow of milk while suckling, which stimulates the breast and the nipple. So what Marge said, the suckling can encourage or can continue stimulating the breast to produce milk. So the nipple stimulation triggers prolactin response. So hence, we are increasing the milk flow of the mom, eventually increasing her confidence in her milk flow. So a dropper or spoon, or in this case, a syringe without needle, can be used. So for this technique, it can be messy because you need to drip the milk from at the top of the breast and drip it while the infant suckles. So some milk will drip across along the around the mouth. So next slide, please. Next slide, please. Okay, so if you can see this one, milk is dripped from a dropper or a cup directly onto the breast while the infant is suckling. So a cloth should be placed underneath the breast of the mother so that to handle the dribbles and the spills in this technique. But it's very helpful because at the same time, the baby thinks that the milk that she is tasting around her lips while you drop the milk comes from her mother, from the breast. And so she suckles more, encourages to suckle more, and thus the nipple stimulation will augment the milk production of the mother. So eventually, if the mother feels that the baby is already satisfied without even augmenting with a drip technique, then you know that the mother already had good milk flow or adequate milk production. Okay, so this would be kind of difficult if there is no one to help the mother. So please, when you teach this one, please have the husband or the partner or any family support to help in this drop and drip technique. Okay, so that's the drop and drip technique. So once the baby is able to suckle on the breast, and the mother has a little milk flow, especially if the mother really has dried up milk supply, then you can sustain this initial success with the next technique. So let's see the next slide. Next slide, please. Next slide, please. All right, so after the baby is able to suckle, there's still that anxiety or the confidence of the mom may not be very much assured that there's really milk flowing. So we can sustain it or supplement it with this second technique, which is the supplemental nursing technique. So if you can see, you don't need very expensive devices for this technique. If we can use it, how does this technique works? We can use a cup or a syringe as shown in this illustrations. So if you can see this will be filled with your expressed breast milk, and then a tube, no? So a French 8 or a French 7 tube can be dipped into the cup or attached to a syringe, and the other tip will be taped on the mother's nipple, just enough on the breast, with the tip just at the level of the nipple, and the baby sucks on this both on the breast and the tip of the tube. So when the baby suckles, milk is being drawn through the tubing, and that will really increase the milk volume that the baby is being the volume of milk that we're giving to the baby. So why is this very relevant for cleft care, for cleft feeding? Because we all know that what is challenging to clefts is that their nutrition, their weight gain. Sometimes what delays their surgery is because of undernutrition or poor weight gain. So we have to admit, we have to be realistic because of the absence of the intraoral negative pressure, especially in cleft palate. They can suckle with some of the techniques we taught you yesterday, but because of the almost zero intraoral negative pressure, they cannot actually empty totally the mother's breast. So to help augment their weight gain, sometimes we need to resort to this kind of supplementation. And this is quite helpful because there you can really taper. It doesn't mean we'll do this forever, but we can taper the amount of milk as the baby gains weight as time goes on. So this is not a one-time success. It will take a lot of days or even weeks not to augment their weight gain. Okay, so if you can see this mother pinching the tubing, why is she pinching the tubing? This will actually, we all know that clefts may have difficulty, may have some form of airway issues or breathing issues. They have a problem, a little issue with coordination of the breathing, swallowing. So, and the process of feeding for them is quite exhaustive. They can get tired easily. So that's why we can regulate the flow through this through this tubing, pinching the tubing, or even if we use the syringe, the drop and drip technique, we can give a constant flow, constant enough that the baby will not get frustrated, but not too fast, that the breathing or the swallowing coordination will be compromised. So they suggested that we intermittently pinch the tubing. Maybe the suggestion was between 3 to 5 sucks to more or less control the flow coming both from the breast and from the tubing. So eventually you can actually taper or wean off the volume. Some protocol shows that we call it top ups. We decrease top ups if based on the weight gain. So if the baby's gaining weight, it means the breast milk production of the mother improved, the suckling has improved, then we can lessen the top up. So if, for example, we top up 6 times a day, we can narrow it down later after 2 weeks, 4 tops up. So these are some of the protocols or the procedures suggested using the supplemental nursing technique. Okay, so this might be very helpful, especially for those who are also relactating. Okay. So next slide, please. Credits to Dr. March on this photo of her patient. So Dr. March taught us on expressing breast milk. So technically, ideally, we give freshly expressed breast milk immediately to our newborn whenever possible. Why? Because the freshest milk has the most preserved nutrients. No? So because you know that as you store longer or you heat or you pasteurize, some immunoprotective properties will decrease in the process. So the ideal is to give freshly expressed breast milk. But what if the baby had enough and there's a lot of milk, you had a lot of milk expressed? You can actually store your breast milk. So how do we store breast milk? We store breast milk at a room temperature. We can store breast milk at room temperature even up to 8 hours, even in our country, even in tropical countries. Okay, we can store it in a lidded container in the coolest part of the room. Or we can store the express milk in BPA-free bottles and milk bags. We can store 24 hours in the body of a refrigerator. You can place it in the coldest part at the back and nearest to the chiller. So that's the suggestion if you want to store it only in the body of the refrigerator. But if you have a freezer, then you can store up to 3 months in the freezer for home storage. So for this one, you can store it in the freezer. More ideal if we have a separate door for the freezer and not a single door refrigerator to keep it more stable in terms of temperature, not always opening and closing the refrigerator. So we can store it for home. These are some of the basic for home storage. Next slide, please. So we also have, next slide, please. Next slide. Okay, so for this one, we have a lot of human milk banks already in our country, and a lot of a lot of countries are already have a very successful human milk banking endeavors also. And these guidelines show some of the ideal storage temperature and duration, and this categorized more into term and preterm. If you just can see, for the preterm, the fresher as possible. So if you can see the difference in the hours, if we give the breast milk to the preterm who is sicker and more immunocompromised, we give the freshest milk as possible. Okay, so again, first in, first out policy, so that we can really provide the most preserved immunoprotective properties in the breast milk. So these are some of the guidelines, and you might want to take a screenshot. We'll not go through with this one by one, because this is more on the human milk banking guidelines. So we made these guidelines, the 3 pioneering milk banks in the Philippines convened and made a Philippine human milk banking guidelines for the Philippine setting. Okay, so next slide, please. So I have touched on human milk banking. So what is human milk banking? Human milk banking is a service. It's not a building. It's a service established for the purpose of screening, collecting, processing, storing, and distributing donor human milk to deserving recipients. Okay, so to meet the specific needs of individuals for whom human milk is prescribed by physicians. So at a glance, if you can see this diagram or algorithm, this is at a glance how human milk banking is being done. So we actually like donor banking, we screen donors, we receive milk, we store properly, we pull, and we do testing, culturing, and we have the holder pasteurization. This is using the ideal temperature where you kill the viruses, we inactivate the viruses, most especially HIV, just enough, the temperature is just enough to inactivate the viruses, but just enough also not to decrease totally the immunoprotective proteins and lysozymes in the breast milk, because we all know heating too high temperature can also deactivate immunoprotective properties. And then we test again and should have 0 bacteria or 0 pathogen, and we distribute to recipients who are really deserving of this human milk, both as therapeutic. This is human milk is considered medicine, especially for our preterms. It prevents a lot of illnesses like sepsis and necrotizing enterocolitis. All right, next slide, please. Next slide, please. Okay, so what are the benefits of human milk banking? The primary benefit of why we do human milk banking, why a lot of hospitals really endeavor to have a human milk bank, because the priority are the hospital recipients, and these are preterm and sick infants. These are the most vulnerable age group, and neonates with surgical conditions, and this will include our cleft lip and cleft palate babies. They may need expressed donor milk for their alternative methods of feeding as we augment and sustain prior and to support their weight gain prior to their corrective surgery, and for mothers undergoing relactation. So these are the benefits of human milk banking. Okay, next slide, please. Okay, and what is the second benefit of human milk banking? And it's very timely, especially in our city, in Cagayan de Oro City, who just experienced the brutality of Typhoon Odette. Human milk banking is very very beneficial during emergency and disaster context. So we can, with the use of the donor milk, we can do breastfeeding missions, and we can give donor milk to separated or orphaned infants, mothers undergoing relaxation in the evacuation site. Because remember, our first strategy will still be to support breastfeeding. And then the human pasteurized donor human milk will come into play if these babies or mothers still need help. Okay. We also give this to infants on mixed or exclusive feeding, and we wanted to transition them back to the breast. And for this picture, for infants with severe acute malnutrition, this is a patient when we did breastfeeding mission in CDO during Typhoon Sendong. We did breastfeeding mission, and most mothers are already breastfeeding. So we just supported the breast to continue breastfeeding. But for this infant, we augmented because this is already at almost 3-year-old child, but having severe acute malnutrition. So because we have a lot of express donor milk left, because most are breastfeeding, which is good news, we left all the express breast milk to this child to really help the child in his nutritional upbuilding. So this is very helpful also in evacuation centers where there's no potable water. So formula feeding is a no-no. Okay, it's adding insult to injury. So let's see. Next slide, please, and let's experience human milk banking for emergencies. Okay, so when we have an express, we do breastfeeding mission, and we will try to do donor milk for the typhoon, or for patients, for the people in the evacuation center. We need to maintain the cold chain for the breast milk to be very viable when it reaches the evacuation site. So for these pictures, we'll show you some images captured during the post-super typhoon Haiyan or Yolanda. So the international name is Haiyan. Did I pronounce that correctly? Haiyan, and then or Yolanda. So it was a very, very strong typhoon, and it really devastated a lot, a lot of families. And if you can see this one, this is the frozen breast milk donated by a lot of institution, mothers, offices. If you can see this one, this is, I think, Miss Claire Mogul of Bangko Sentral ng Pilipinas, really donating, collecting milk, doing volunteer work. And this milk were transported to, were pasteurized by the human milk banks in Manila. And after pasteurization, it was transported to Cebu or Busuanga or Leyte or Tacloban through the efforts of the Philippine Air Force, which landed in Lapu-Lapu in Cebu. And if you can see this one, this bangka there, the boat, sorry for the term, bangka is the local term for that small vessel, wooden vessel. For this, the breast milk is being delivered to the Busuanga, airlifted and delivered to Busuanga, the point of the last handfall of Typhoon Yolanda. And this milk were all coming from Metro Manila, Cebu, Cagayan de Oro, through the efforts also of our different mother support groups and other lay people. So it was a very emotional experience and very meaningful. It's the best help we can do, as healthcare advocates for our infants. So we really advocate for infants here. So it was a very nice experience. Next slide, please. Next slide, please. So thank you to all the efforts, and especially to Mamian and the KMI. And this slide shows that that disaster work can be documented, can be published, and so that people may know, may learn. Okay, so sometimes during disasters, we are so eager to just go and help without anybody documenting the narratives behind it, the behind the scenes emotional experiences of people, the happiness, the joy, the struggles. No? So all of this should be documented. And disaster work is really a meaningful work for everyone. Okay, so next slide, please. Next slide, please. So I encourage you to read this journal. Okay, and these are the human milk banks in the Philippines. There are 23 in Luzon. Mostly, if you can see, most milk banks are clustered in the Luzon area. So in NCR alone, we have 17. So that's almost more than 50% of the total milk banks in the country. And there are only a few in Region 1 in Ilocos Norte. There are 2 only. And in Tuguegarao, in Baguio, only 1. So Region 3, only 1. In Naga, only 1. Usually these are the disaster-prone areas also. Batangas City, only 1. Next slide, please. Next slide, please. Next slide, please. So in Visayas, Visayas currently is experiencing the worst part of Typhoon Odette. So we have to pray for Cebu, Bohol, and Palawan, and Tacloban. So if you can see, we only have 2 in Cebu. We only have 2 in Cebu, and there might be others like in there are only 2 in Visayas, and there might be others trying to establish like Cebu, but they still lack some operational requirements. And in Mindanao, next slide please, we only have, next slide. Next slide. We only have 3 in Region 10, 11, and 9, no? Cagayan de Oro, Davao, and Zamboanga. In Cagayan de Oro, we also have 1 more coming up. We have 1 more coming up, and it will be in a city hospital. But for now, these are the operational human milk banks. So what is the point of this map? The point of this map is that most of the human milk banking institution is very, very established here in the Philippines, but most are concentrated in the Luzon area or in the national capital region. And if we can see, our country is an archipelago, and it is disaster that this island, some islands are really disaster prone. So there is a call to really establish more milk banks across the country. And so that anytime we are faced with emergencies and disasters, we have the nearest milk bank where people can send their milk to be pasteurized and to be ready to be given to the disaster victims in evacuation centers. Okay, so I think that's my last slide. Next slide, please. Okay, so thank you so much, and I hope you learned a lot from our discussion of Doc Marge and Dr. Joanne. And I hope we discussed already alternative feedings, expression, storage, and higher up human milk banking. So thank you for listening. So may we call on Ma'am Pinky?
Thank you, Dr. Jessa. I'm sure everyone will agree. We've had very excellent speakers. So may I call on Drs. Joanne and Dr. Marge to join Dr. Jessa. Now comes the exciting part of interacting with our speakers. So my disclosure is I'm a pediatrician, but I still found myself hanging onto every word that our speakers were saying. And as we are all adult learners, the demonstrations and the videos really drove home the points, the very important points that our speakers wanted to tell us. So let's go first to the questions that we have in our chat box. The first question we have, I think, asks about a subject that we already touched on a little bit yesterday. And our question is, how do we support mothers? The first question is how to prepare a pregnant mother who was diagnosed antenatally, her baby to have cleft. So prenatally, what can we do to counsel these mothers?
Okay, can I start? Because
Yes,
Yeah.
go ahead.
Go ahead,
Yeah,
Doc.
alright. So, because I offer perinatal counseling in my clinic, and I receive some mothers who are I receive them quite depressed with an ultrasound result. Usually, earliest is 20 weeks. You can detect cleft lip and palate by then, and no parents want to hear that their child is having a cleft lip or palate or any craniofacial anomaly. So it can be very highly emotional for them. So what we can do is we and let the mother also stay calm, because with preparation after birth and corrective surgery, most of these babies can actually develop normally. Now they can grow up to be normal kids if there's no syndrome involved. Okay, so if there's non-syndromic, we always reiterate that children with cleft can develop normally. Their progression of growth is still the same as normal kids. No, so we really reassure the parents that there is surgery. There's something that you can do for the infant when the baby is born. And we have to reassure them also, because sometimes they will think, the mother will feel guilty. Did I eat something that made the deformity? Did I took a drug? So they will have this, they have this guilt feelings. And so we have to reassure them that this anomaly can't be prevented. It's a combination of genes and environment. And sometimes it's even an unknown, due to unknown cause. And you might also want to prepare them that maybe genetic workup will still be done, because cleft lip and palate can be associated with other syndrome. And if it's associated with other syndrome, there's a more greater preparation depending on the other anomalies associated. And what we can also prepare them is tell them there is help available. There are resources online, because knowledge is power. So information is power. So sorry, okay. So information is power. So we give them what we can in terms of information and publication, and we build their confidence, their breastfeeding. Tell them that we are there to walk through their breastfeeding journey. Don't tell them that it will be a bed of roses, that breastfeeding is easy breezy. So we have to warn them. That breastfeeding can be a struggle for them, for these babies. And so just reassure them that we will be there to guide them. There will be lactation specialists like Joanne and Marge to be there for them. So tell them, just reassure them that they will have help after the birth. And there's the surgery. That's the surgery. And there's teamwork also that should be involved. Prepare them also that there will be a lot of consults from orthodontics, dentists, nutritionists around. So, but this team can help really prepare them more fully to allow their child to have the most optimal optimal course of development. So, and then let them connect with others, like peer support groups. I'm sure there is a cleft lip and palate support groups around, no? And the clinic of Dr. Marge, no? So you can really patch them up with other mothers who have successful stories, who also have their cleft lip and babies are really growing beautifully also, like any normal kid. So that's my take. No? So how about Marge and Joanne?
Well, adding to what Doc Jessa already mentioned, I think it's very important for anticipatory guidance to be given. We have to walk through what they will be expecting in the early days, teach them hand expression, teach them how to collect. With the knowledge, we should give them practical advice. Okay, emphasize to them how important the unang yakap or the EINC is. Okay, and then just like what Doc said, we have to patch them up with the nearest breastfeeding support group to them, because proximity and availability of the help is really paramount to success. And then coming up with a circle, perhaps soon with Smile Train, we would be able to come up with a group chat perhaps of Cleft moms who are pregnant with cleft babies and families who are already taking care of their babies with cleft, so that we make the support more felt and more tangible for these families.
Dr. March, how about if the family is living in a far-flung area? What would be the best thing for them to do? They're 3 mountains away from the urban center, and they find out that the fetus or the baby the mother is carrying seems to have a cleft deformity.
That's the challenge I really had to deal with, being one of the first Smile Train partners in the country. I had to be patched up with moms all the way from the north, even from Mindanao, even before they came. I think the silver lining of the pandemic is that we learned to use and abuse social media and FB messaging. We make use of any platform available to us, even if that would mean we do phone calls or maybe share some FB posts to them. The webinars that we have done with Smile Train is there. So I share to them the link because I know internet can really be a challenge, especially in far-flung areas. But it is very important to know what mother support group is nearest to them, because the only way for the support I give them virtually is for them to see a mom who may not be dealing with a cleft child but knows how to handle breastfeeding already and has had enough experience as to how it is like the waking up in the early morning, okay, to help this mom have a better understanding of what is happening.
Dr. Joanne, you have anything more to add to our prenatal counseling?
Nothing else to add po.
Yeah.
Yes, Jessa.
Regarding the remote areas, the question on remote areas, this is also a challenge to us and the KMI and Smile Train to invite more barangay health workers across the country who are assigned to the remote areas or barangay, to gather them up and teach like this kind of webinar so that they can transfer knowledge to the barangay level. So we are teaching the DIY. We are not teaching expensive alternative methods anyway. So we can do DIY, do it yourself, resourceful apparatus in the areas to teach these moms with cleft infants how to do alternative feedings, and to tell them that really, if possible, with the help of an LGU, prepare them to go to the urban center for further corrective surgery. But in the meantime, if I don't think if we can do the transfer of knowledge to barangay health workers and nutrition scholars, and even breastfeeding women assigned for every community, there's usually an assigned breastfeeding group by then LGU, so it might be doable. Thank you.
Most of the time, the people who would subscribe to Smile Train are those in the rural areas or are financially incapable to really, buy those contraptions, those branded contraptions. That's why we in the community area has learned, okay, through years of practice with Arugaan, that you can actually make use of household items. A spoon can be used as a feeder. You don't need to buy something as expensive, and it's just as effective if only the mom is properly guided. So that's why we wanted to share this best practice to our attendees, because we wanted really to empower them as enablers and transfer that empowerment to the families who are dealing with this predicament.
The first take-home message here is it can be done, no? For us to help educate the mothers and for the mothers to do it themselves. On the other side of the coin, post-surgery, what would be the practical advice? Now, there's a question here on how to advise the mothers post-surgery also.
I think if we're able to teach them cup feeding early on, by the time the child undergoes surgery, such as if you remember the picture I showed you of baby C, the one drinking in the nifty cup, the skill became very useful for them when the child who recently had surgery, both for the repair of the palate and the lip, The cup feeding was something that helped them because there's no need to suckle onto a tip that will add pressure onto the suture site. So really guiding them early on and being available for them for consult is very important, because if they learn how to do it, they will do it like it's something normal to them.
A related question to that, no? There's a question from one of our participants. Dear speakers, I met a few cleft patients who were breastfed prior to surgery, but after the surgery, it would be difficult for the mother to do the breastfeeding again due to the wound. So in your experience, what should actually be recommended to the mothers to feed the baby? What are the methods that would help them to feed again after surgery?
I think the question here is really about the mother who's really not in, inkling to breastfeeding after the surgery. So if I remember right, in one of our lectures yesterday, how early can we breastfeed a baby after a cleft lip repair and after a cleft palate repair? It will not take that much of a time, and it wouldn't require that much of a time to wait. While waiting, we can do cup feeding, but also we need to also support the mother to sustain the breast milk, their milk supply, for the time when the time comes that the baby can breastfeed again. So actually, relactation is far from what we need to consider in this case, because the babies are already breastfeeding in the first place. And since breastfeeding is for the infants, our muscle memory, it's very easy for them to do it again. Not unless you stop breastfeeding for a month or two. So maybe then the difficulty will come.
And we'll tackle relactation in our next session. No?
Yes.
Regarding, this is for Dr. Jessa, regarding the human milk banks, how do you keep your supply? How do you get your milk supply to stock up in your milk bank?
Okay, so every human milk bank needs to have sustainability programs. So it's the milk bank who's planning their activities tailored to their hospital setting on how to top up their milk supply that they won't be drained. Because if there are no breastfeeding donors, there's no breast milk supply, there's no milk bank at all. Okay, so first and foremost, we still go by our strategy to support breastfeeding mothers admitted in the hospital. So if you have successful breastfeeding women discharged, you have potential milk donors in the hospital. No? So we patch up with them after discharge, and once they have enough milk, we encourage volunteerism for them to donate their milk. And we also have, by experience with other hospitals with milk banks, they also have this milk bank, daily milk bank collection schedule at the maternal wards, where they can collect, they'll try to collect breast milk from the wards every day. Okay, so that they won't really lose supply. Next is we can do community missions. We can do breastfeeding collection or breastfeeding milk letting activity. I'm sorry, we call it, we have donor blood letting activity. So at the same time, we do have milk letting activities. We can organize milk letting activities. So instead of donating blood, the mothers go to the hospital and express their milk, and whatever they produce, they donate it to the hospital. That's one of the various activities we can do. And then other strategies that we can do is patch up with a rural health center and barangay health center, maybe during their immunization days. We can do collection, teaching them first how to express well, cleaning, washing, sterilizing their equipment for expression, and do the milk letting while the mothers are there. So that's one of the LGU LGU partnership with the hospital. And last but not the least, we patch up with mother support groups in our area. And in my experience, it's really the mother support groups through social media, through their chat groups, who are gathering the breast milk for us. No? So those have extra stash, they donate to they go to the hospital to send their milk. So very powerful to have a very good partner. The Human Milk Bank will have a good partner, mother support group. So acknowledgement to Cagayan de Oro, the mother support group, Modern Nanays of Mindanao, our biggest partner in human milk banking. So these are some of the strategies that we can implement to improve the collection, the milk collection in the milk banks.
Dr. Jessa, if I may add, if we
Yes.
have a very strong education department when we talk of breastfeeding, if we empower moms very early, there's very little need for milk banks in reality.
True.
Because if they know how to breastfeed and maintain it, and they can look past some of the obstacles early on, they will not be calling for, and the milk bank would just be for the purpose really of very, very sick babies. So if we are able to strengthen the support and the education of breastfeeding for moms even before they give birth and they are well supported up until they give birth and they go back to the community, the milk banks will not have any problems with donations, or there will be very little need for it. But we want to be ready all the time.
Yeah, that's why milk banks have this prioritization.
Yes.
There's a list. It's not a dole out strategy. There's a prioritization. So we give first to the sickest preterm, and then sick term, and then surgical. And if somebody is asking, can I ask milk? How old is your baby? Is your baby full term? Yes, full term. We don't give milk. We really assess first that. So then we go back now to the position, attachment, suckling. The question is, why is this mother needing donated milk? The baby is well. The baby is full term. So this is not a sick baby. So that's when we go back to our supporting the breastfeeding strategies. So Human Milk Bank will always be a standby source for the sick patients in the hospital, and the rest of the pool can be for emergencies and disasters. So that's why we are happy when we do emergencies. If we have excess donor milk, we're actually happy that if we have the excess donor milk, because it means we still have a lot of breastfeeding women in the evacuation centers. So I agree with Marge that we don't need a lot of supply if most of our mothers are already breastfeeding. Yeah.
True, no? So our second take-home point is human milk banks are not the first resort if you don't have milk, but rather a last resort. No? Even in our hospital, Pabella Hospital, we prioritize the preterms, and rarely do the mothers can come in and buy 2 or 3 times. No? Usually first time is okay, second time, she should have been counseled already. And we do reserve part of it for emergency purposes for donations. So I think Dr. Jessa will activate again her mother's groups now in the next week, no?
I actually posted this morning. I actually
after
call for breast milk.
That's right. Okay.
For our
we have one more question, but I think do you want to answer this now or later? It's about wet nursing by women who are not postpartum. So these are like grandmothers or nulliparous women. Is it possible? Do you think we should tackle this in the relaxation, or
Joanne? Would you like to discuss this, Joanne, now or after your relaxation?
Well, it's a different topic altogether, but it is possible. There are some cultures that do it. There are Filipina grandmothers who actually are relactate or with induced lactation, but it does happen. It's mostly anecdotal, but it does happen.
Would you say, is there a difference in the kind of milk that they produce if they were nulliparous, or it's the same still? Breast milk is still...
It is the same scientifically. It is the same. When the breast milk is produced, is 100% what the baby needs.
Okay, so I hope that answers the question, but we'll know more in the next session. I hate to cut this short, but we have another session, and of course, our excellent speakers will come back after that. So we can go on to our next session. Thank you again to Doctors Jessa, Joanne, and Marge.
Okay, good afternoon again, everyone. We are down to our last lecture, but this one is a rather daunting topic, and I am with my partner, Dr. March, to discuss to you about relaxation. Next slide. At the end of this session, we would like our learners to be able to define relaxation, recall the study on relaxation done in a tertiary hospital in the Philippines, to enumerate the elements of a good relaxation program, and to contextualize the relaxation program in their own country settings. Next slide, please. Okay. In 2015, it was reported by the World Health Organization, together with the UNICEF, that only 1 out of 3 Filipino breastfeeding mothers continue to exclusively breastfeed up to the recommended age of 6 months. This breastfeeding rate remained to be the same in our global breastfeeding scorecard in 2018. The next slide will show you the common reasons the mothers had for discontinuing breastfeeding earlier than expected. Next slide, please. Some mothers who gave birth in the hospital or lying in clinics reportedly never received breastfeeding care and had zero knowledge about breastfeeding when they get home. That's so unfortunate. Others, however, may have started breastfeeding really well, only to compare their milk supply to another mother. And when they start to think they were not at par with other mothers, they try to discontinue breastfeeding. And before the pandemic strikes, many Filipino mothers actually worked far from home as helpers, and babies were left to the care of their grandparents or the father. Breastfeeding usually stopped prematurely to allow them to get back to work. You can see the picture on the right, a whole room of bottle feeding infants admitted for pneumonia whose carers were either the grandmother or the father. You can even see one father there bottle feeding his son. We know now that formula feeding increases the risk of pneumonia and diarrhea. And here is a proof of that, a whole room of sick babies. When asked, their mothers work far from home to bring food to the table and stop breastfeeding prematurely. Postpartum depression is also a real and emerging problem for many new mothers. It also causes them to stop breastfeeding early. Some mothers were also told that if they were to breastfeed, it means that their family is poor and couldn't afford formula milk. Breastfeeding misinformation also exists, even until now. In this year and age, mothers are sometimes told that breastfeeding will render them unable to rest and may cause a delay to their baby's independence. There are also myths that they couldn't breastfeed when they are tired or sick. This caused the mothers to stop breastfeeding earlier than what is recommended. Next slide, please. On a positive note, due to the widespread and emerging campaigns about breastfeeding found in social media worldwide and staunch breastfeeding supporters, mothers who stop breastfeeding start to welcome the idea of relaxation. The picture on the left is a proof of that. These mothers wanted to relactate their babies. However, existing international relactation techniques require the use of breast pumps, expressed breast milk, galactagogues, and other costly paraphernalias. Relactation in the Philippine community actually exists, but this has been largely anecdotal, unrecognized by the medical and scientific community. Hence, the mothers look to health workers for breastfeeding and relactation support. Next slide. One of the widely accepted relactation protocol is that of Dr. Jack Newman and Lenore Goldfarb, which I believe is actually based on the positive feedback mechanism of lactation. This mechanism simply tells us that more frequent direct breastfeeding stimulates greater milk production, as has been told to us over and over again since day one. We love Dr. Newman's protocol because it is one of the protocols that are actually effective. Be that as it may, since this protocol is usually used in the Western countries, the protocol made use of galactagogues and breast pumps that their insurances could easily provide. This may not be applicable in many country settings, especially with the mothers in the grassroots level, even so with the many attendees that we have today. It is for this reason that back in 2016, I thought of a study that may fill this gap of knowledge. What techniques, if put together, could be used to bring back babies to their mother's breasts, sans the benefit of the costly products that is not available in every country? Next slide. My study, entitled A Novel Relaxation Program Among Bottle Feeding Inpatients in a Tertiary Public Hospital in the Philippines, run for 6 months from 2016 to 2017. It was started due to positive guidance on relaxation among health workers. And I would like to share it with you. We describe a novel relaxation program for inpatient bottle feeding infants at the Philippine National Children's Hospital. Next slide, please. Okay, so as our operational definition, relactation is a process of re-establishing lactation after initial discontinuation. And by re-establishing lactation, we mean overcoming two main challenges. First is the decreased milk supply of the mother due to lack of stimulation. And the second is the infant's preference to silicone nipple due to prolonged bottle feeding. In order to be definite with our population, we actually tightened our selection criteria. This study included mom and baby dyads of sick but stable, exclusively bottle-fed infants admitted at National Children's Hospital. In order to be included, the mother should self-report that she has low milk supply. The nurse would then confirm the mother's milk supply in person after demonstrating the proper way of expression. The mother who had 5 ml, 5 cc or less of expressed milk output after 15 minutes of breast milk expression will be enrolled. Since the study had an intention to treat priority, we excluded infants who were ordered non-per-orem or those who cannot drink or feed, those who are unstable or on mechanical support. We would withdraw the enrolled dyads when there is clinical deterioration or the infant is placed on non-per-orem or if the dyads fail to follow up on day 14 and 21 of our intervention. Next slide, please. So our 21-day intervention include the following elements. Upon enrollment, the mothers underwent a 30-minute standard breastfeeding education session. Using a flip chart, we discussed the following topics: advantages of breastfeeding, disadvantages of bottle feeding, the physiology of lactation, the supply and demand mechanism, which means the more demand, the more supply. Okay, I cannot emphasize this enough. And infants' hunger and satiety cues to unlearn the every 3 to 4 hour feeding bottle schedule of infants. And then we also discussed proper positioning and attachment and the basic breastfeeding and relactation skills. Mothers were also required to do skin-to-skin contact daily for at least 2 continuous hours per day. We know that skin-to-skin contact helps regulate the infant's temperature, breathing, heart rate. It also promotes weight gain. I would like to emphasize that no feeding bottles, no breast pumps, no galactagogues were used in this study. Here's an in-depth look on the different elements. Okay, right, next slide, please. Another one, after proper demonstration and return demonstration, the mother is asked to direct breastfeed 8 to 12 times a day with supplementation via the drop and drip technique. The technique that Dr. Rajesa taught you in the previous lecture, with the use of either a spoon or a dropper. You can see here in the picture the nurse that used a syringe for the drop and drip technique. And this is credits to the Arugaan technique. They made use of spoon. So we really actually don't need to find the syringe in the rural areas. We can actually use a spoon. Okay, so um, so with the help of a dropper or a spoon or a needle-less syringe, milk is dropped on the mother's breast and allowed to drip into the corner of the baby's mouth. This tricks the baby of the source of the copious milk and encourages him to suckle more vigorously. As we all know, the more demand, the more supply. They were also taught to do manual breast milk expression, both to measure the volume of mother's milk and also to help drain milk for whenever the baby absolutely refuses to breastfeed directly. Self-breast massage helps stimulate the mother's breasts, provide relaxation, and even visualize their milk supply. Hence, we also taught the Arugaan method of self-breast massage both to the mother and her husband. I would like to emphasize again that there were no feeding bottles, no breast pump, no galactagogues used in this study. I don't know why I keep repeating that, but I feel proud about saying that. Next slide, please. Okay, so for when the baby absolutely refuses to suckle directly, mothers were taught to cup feed as an alternative feeding method. They were encouraged to try breastfeeding again once the baby calms down. So after that, monitoring was done every 2 to 3 days while they were admitted in the hospital. We recorded the mother's expressed breast milk after 15 minutes of expression every visit, the report of direct breastfeedings per day, and the infant's weight gain per day. Critical milestones were measured such as the letter A, the number of days to increased volume of hand-expressed breast milk accompanied by sustained infant suckling, and B, the number of days to partial relactation success, which we defined as greater than 2 full feeds in 24 hours, each not requiring supplementation, as verified by a trained personnel. So outcomes were classified as complete relactation. That means if the baby achieved complete relactation, no supplementation was ever needed in 24 hours, and this result should be maintained until the 21 days of intervention is finished. Okay, and the partial relactation, I have told you before, greater than 2 full feeds in 24 hours without the need of supplementation. And of course, another outcome could be failure. That means whatever we did, however we did the intervention, the baby still refused to breastfeed, and the mother was not able to produce more milk. Next slide, please. So here are the study's primary outcome. There were a total of 43 enrollees. 8 mom and baby diets were withdrawn as they failed to visit on their day 14 and day 21 outpatient department follow-up and were unreachable via calls or messages during that time. So we ended up with 35 finished, still a good amount. No, it's a good number of responders. 35 finished the 21-day intervention. Of the 35 dyads who finished the 21-day novel relactation program, 34 achieved relactation success. 25 of the 34 were exclusively breastfeeding at the end of the program, while 9 mixed fed. Only 1 dyad failed to relactate despite the intervention. So if we can see that, that's already 97.41% successful relactation. 71.4% of that is complete relactation success, while only 25.7% were mixed fed. That's a good outcome, isn't it? And only one failed to relactate. Next slide, please. We go to our secondary outcomes, which is also interesting. For our critical milestone A, you can see on that first diagram or the first picture, it took only as early as 2 days, but an average of 4 days before an increase in milk supply from the baseline, which is less than 5 cc of milk, was first noted. The longest that we had to wait before milk supply increase was 10 days. Concurrently, it was also as early as 2 days and an average of 4 to 6 days before partial relactation success was achieved. Considering that the infants were sick at this time and admitted in a hospital setting, this outcome is favorable. Don't you agree? Next slide, please. The mean volume of milk output per expression among those who relactated, mind you, was only around 30 to 35 ml. This average volume were consistent despite the baby showing already signs of spontaneous suckling, the baby's satisfied, the baby has been showing signs of well-being, steady weight gain, and after some initial losses. You know what? This supports the idea that the milk output via expression or while you hand express is not reflective of the mother's real milk supply. You see, so we found out that these babies has already been successfully relactated, but the mothers can only just express 35 grams per day. All right. Okay, next, it took an average of 4 to 6 days before consecutive weight gains were observed, while the babies were recovering from the reason of their admission, and their average daily weight gain once they partially relactated was about 35 grams per day. This rate of weight gain is more than acceptable for us pediatricians because for us, 20 to 30 grams per day of weight gain is already a lot. So this is really a favorable outcome. Next slide, please. Well, previous studies revealed that relactation takes longer in infants with advanced age. Those may be 3 months old, 4 months old, 5 months old, up to 6 months old before they get to complementary feeding. No, and it might be directly proportional to the amount of time that the baby previously did not breastfeed. That means, or the lactation gap, that means if I did not breastfeed for a longer time, it will take longer for me to relactate. It was not the case in this study. This study showed that infant age and lactation gap has no correlation to the amount of time before relactation was achieved. This was done statistically. So for my conclusion, we demonstrate the strong feasibility of a 21-day relactation program. Sorry, Sir Alex, that slide. Okay, so we demonstrate the strong feasibility of 21-day relactation program in a low resource inpatient setting without the use of human milk bank, hospital grade breast pump, galactagogues, or lactation aids. The high yield of relactation success, despite resource limitations, show that breastfeeding knowledge and skills transfer are essential for novel relactation program to work. Okay, next slide, please. Some of our study limitations were the program was first designed for inpatients who were constantly monitored by the hospital staff, which is a controlled environment. They also received support from the mothers admitted in the same ward as them. So when the moms feel like, okay, it's overly challenging, the mothers who are also doing the same intervention, or also maybe they are mixed with other mothers who are breastfeeding, they have mothers to support them in the same room. Okay. Second is the communication and the follow-up were difficult. Once the patients were discharged, and this was 2016, and our data, our telecommunications are not that good, still not that good, right? But it was extremely difficult for us once the patients were discharged we had a hard time calling them, so hence the number of withdrawals. But these patients who withdrew actually were completely relactated before they went home, but they failed to come back for their day 14 and day 21. Looking back, we should have visited the patients who failed to physically follow up. However, since we also have other jobs in the hospital, so we weren't able to do this. Okay, next is the intervention, and the observation period was long at 21 days. All of our subjects, except one, achieved outcome at a much shorter time. If I remember right, I already told you as late as 10 days, we already have a result. Also, sustaining the outcomes of relactation success would be more difficult at home, considering several confounding factors such as familiar support, mother's determination, and return to work. Next slide. Okay. Some of our study limitations. Okay. All right, I've said that already. So based on the limitations of our study, we recommend a similar study to be done on well babies in an outpatient basis to reflect the outcomes of the general population who would attempt relactation, and to create a more stringent communication and follow-up platform for enrollees of a relactation study. Okay. And lastly, we recommend a shortened intervention and monitoring period based on our data that outcomes were already achieved as early as 4 days and as late as 10 days. I have a few slides before I end, but you can see this picture. I obtained the mother's permission to share this, and you can even see my picture there when I was younger 4 years ago. This is baby Ruth and her mom. Okay, she was admitted because of ileal stenosis. That was a problem in the small intestine, and she was severely malnourished because of it. And then she went surgery. After the surgery, once she was deemed stable and the non-per-rem order was lifted, actually, initially the doctors wanted to start the baby on orogastric tube feeding continuously with milk, with formula milk. How even when the baby already showed signs of, she can already feed orally by herself. This mother, however, she was adamant on relactating and refused the doctor. So upon the mother's request, she talked to us. She wants to be included in the study. We had to really ask the clearance from her doctor, from her attending physician in the hospital, to be signed in to our study. Okay. So upon her mother's request, with the clearance and referral of her attending physician, eventually the attending physician referred to us because the attending physician said, yes, she's stable enough for the intervention. So she also passed the inclusion criteria. So they were enrolled in our study. They underwent the intervention, and here she is. Look at day 14. She's still in the hospital there. Okay. So you can already, the cheeks filling in, and she's already awake, you know, and active. On day 21, that was their last day admitted in the hospital. So look at her. And then she went back. Actually, she already finished the study, but she went back on day 30, and look at her. She looks like a normal baby. It looks like that she never went to any of those obstacles, you know. Um, right, and then they came back to visit on day 60, and look at her. Okay, so you can see the one with the long hair. That's me, and and Ruth and the mother. Okay, next slide, please. Today, baby Ruth is 5 years old and in preschool. Her development was at par with age. This just goes to show that when the intervention was done early, you know, and it just goes to show that relactation is really a powerful tool for the mother and the baby. Next slide. So So we're done with that study. After a few years, I've started my private practice. I was able to see about 72 mothers having breastfeeding concerns. Maybe more than half of them, they said they want to be relactated, but actually, very few indeed needed relactation, really. Some of them just needs to be encouraged, some of them just need to be counseled, some of them just need a further boost in their milk supply, but very few indeed really needed relactation. However, after an in-depth counseling and goal setting, this mom and baby dayas who wanted to relactate, only a few of those who inquired proceeded with the relactation intervention. And we did it mostly face-to-face or teleconsultation, especially when the pandemic started. Okay, outpatient follow-up has usually been fluid as they are constrained by their own family support and schedules, or even the pandemic precludes them to come. So it was an eye opener for me also. But the goals that we've done, based even on the studies that we've done, the goals have been more realistic, and there have been more confounding variables. So it's more true to life. To those who still pursued relactation, however, I usually did multiple 1 hour sessions of face-to-face or virtual consultations. That being said, I still could recall at least 10 out of 12 mothers successfully completely relactate, and the others are mixed feeding at least 14 days after the intervention. This just shows us that the methods that we've done is in the study were still applicable. The relactation techniques, it's still applicable to the general population. So I think that ends my lecture. I will now turn you over to Dr. March because she also has more experiences on relactation in the outpatient setting. So thanks for listening. Dr. March, take it away.
Dr. Ann, I'm always in awe every time you present your research, because it shows to us how amazing our bodies are created by the Lord God. And it is because of that study that we came together, Dr. Joanne, Nurse Nadine, okay, and decided to come up with a live stream webinar on relactation. Okay, we understand that this happened around the time of the pandemic, and the pandemic has really caused us to have some paradigm shift. And while the pandemic caused us many challenges, it presented to us many opportunities in the field of breastfeeding and lactation. We were able to use social media platforms to bring our message across. We have done many webinars, such as I have mentioned previously in our webinar. One of those silver linings, I guess, would be this all about relactation webinar live stream that we did. And based on the data that we tried to start, just to monitor how many moms were able to meet. Although if you can see in the picture, it says there, it has about 26,000 views up to date. I haven't checked it recently, but we surfaced a Google form at the time, and we found out that during the initial feature of this webinar, based on the study of Dr. Joanne, about 148 moms reach out for relactation support. And when we find out as to where they are located, we would refer them to the nearest breastfeeding support group, because as I have mentioned, it is paramount for them to have access to skilled help. Many of the moms in this 148 who sought assistance for relactation were mixed feeding. And we found out, just as what Dr. John mentioned, this actually would resonate to what she has discussed. Only needed guidance, skilled assistance, because they have perceived low supply, usually based on the pump outputs or crying, which we have mentioned, Dr. Joanne mentioned, isn't really the main, the most sensitive indicator to see if mom's supply is really enough. We found out, okay, through this study that there were about, for this year, from the time that webinar was done, in my clinic, I have met around 16 dyads who had legitimate supply issues. And based on my practice from the time that we have done this relaxation webinar, there were about 10 cases of relactation that I have personally handled, the oldest of which was 10 months old, which also surprised me, truth be told. Okay, next slide, please. So, like what Doc Joanne mentioned a while ago, when we talk of relactation, this is a process of bringing back or inducing breast milk production. There is a twofold or an essentially twofold process involved for this to happen. Okay, one, which can be the hardest, is bringing baby back to breast, especially if the child has been bottle fed for a long time. Okay, there is unlearning and relearning that needs to be done, not only by the infant, but the mother themselves. Both mom and baby should unlearn dependence on bottles. Next, we would want to establish or re-establish mother's breast milk supply. Now, inspired by the study of Doc Joanne, next slide, please. When we came together, when Nadine and Doc Joanne came together, we discussed what are the things that are needed by these families when they are to pursue or to undergo relactation. Come to think of it, reading the slides now, it's not only in relactation this is needed. It is needed all throughout the breastfeeding journey, more so for families with cleft. There are 4H for us to easily recall the things that these families need. The first H is head, which means right information, evidence-based information, accurate information, and the right mindset and headspace. I remember Nana Ines, who is one of our mentors, Doc Joanne and I, always would say breastfeeding is 90% psychological and 10% physical, which is true because physiologically we are designed for it, and the maternal headspace affects her neurotransmitters, her hormones that would have an effect on her ability to produce milk. So it is really important, no, for us to spend time on educating the families about breastfeeding, tell them what to expect. Explain to them the pros and cons of whatever choices they can have so that they come to a sound, well-informed decision. Next is heart. Okay, we need the families to take courage, to develop self-confidence. I find as a clinician that most moms just have, you know, a little dip of self-confidence. They have a tendency to compare themselves to other moms, especially with social media, them seeing other moms posting of their milk stash. Okay, and I have to always remind the moms, Mommy, you are not measured in ounces. Breastfeeding is not about just milk production and milk supply. So it's really important for this to be touched, no? As a counselor, you have to empower the parents, teach them, guide them to have that courage and to have trust in their capacity, trust the process and trust the product. Next is hand. They need to be guided with proper skills of how to hold, attach their babies to the breast, how to hand express, because these are the necessary skills that would help them to be able to forgo or to continue rather their breastfeeding relationship. Next, H is help, and this is what we intend to strengthen with this webinar. We need support to be more felt, to be more accessible, to be widely available. The help should also involve the family. I find that as a breastfeeding consultant, many moms would have a little struggle in terms of family support. And that's why as a counselor, as a consultant, I would always require that a family member is there. Even most especially for our Smile Train clients, I would require somebody to come with the mom, someone who is closely involved with taking care of the infant. Next slide, please. Inspired by the study of Doc Gallardo, we thought of, when we did the webinar, we wanted to come up with a mnemonic that will help our attendees to remember how the house and the things that they can look for to see if they're effectively achieving their breastfeeding goal. Baliksuso in Tagalog, Baliksuso rather, is a Filipino word which literally means back to breast. And so we divided the process into two parts: the balik, which refers to how to start the relactation, or how to achieve relactation by following these 5 core steps. That is breastfeeding directly at the breast 8 to 12 times in 24 hours, utilizing the drip drop method to entice the baby to suckle. We also thought about proper latch and positioning. We taught them how to do hand expression and self-breast massage. We taught them, and this is one of the more controversial parts of the step, but we feel is essential, is we had to inspire them and guide them to really ditch the bottle and pacifier. That's I. Itapon ang bote at pacifier. And then K, we had to do a lot of kangaroo mother care, skin to skin. As previously discussed in our lecture in day 1, we learned that this jump starts, okay? This returns the innate behavior of the infant towards the breast as it stimulates the mother's milk supply and increases, the bonding. Okay. We also used the second part of the Baliksuso, which is suso, literally in Filipino means breast. Okay. We tried to come up with things the family can, or the moms can observe to see if they are already achieving their goals toward relactation. Next slide, please. Now the question would be this: Doc, you did this study for babies who had no cleft. And we wanted to make sure, and this is one of the things that we really thought of, Dr. Joanne and I, when we were preparing this webinar. We wanted this study to be used, okay, and contextualize it for cleft care. And so we thought of 2 words, and Smile Baby. The first step, and I hope everybody's taking note of it, the very first step to relactation is, of course, doing skin-to-skin contact. As I have mentioned a while ago, it is essential because we would want the innate behaviors of the infant. You see, when the babies, we are ventral feeders. And so when a mammal or a human baby is placed on the chest of the moms, it triggers the innate behavior to look for the breast. There's so many things about how our bodies were designed that's really amazing. Even the areola smells like the amniotic fluid, just as what Doc Mian mentioned yesterday, that the hands of baby also has that same scent, which allows the baby to root back and find the breast for them to feed. Next, we have to maintain direct breastfeeding, again, 8 to 12 times in 24 hours. If we really want to relactate, then this has to be done. And in some cases, we might need to do drip drop, okay? Or for some, they might have to use DSNS, just so the baby is able to empty mommy's breast, which will trigger more supply. And by doing DSNS with this one, you are able to feed and you are ensured that the child is fed, which is most of the time the concern of the mother. Next, individualized support and breastfeeding is important. It's really something that is paramount to success. If the moms understand why they are doing this, if they understand the pros and the cons, they are better equipped and empowered to choose what is best for their child. Lactation skills is also taught, that's letter L, and that would include positioning, hand expression, self-breast massage, which will also empower the mom and boost her confidence. It also allows us to monitor how much milk she's already producing, although it's not the most sensitive indicator. Of course, if our intention is to breastfeed, the shortest distance between 2 points is a straight line. We want to eliminate bottles and teats. Please do understand that when we say we eliminate bottles and teats, it doesn't mean we will not feed the child alternatively. In fact, if needed, if the milk supply is not yet as abundant as we would want it to be, the moms may cup feed or dropper feed or spoon feed or feed at the breast or supplement at the breast as needed to ensure that the child is fed while they're undergoing relactation. Next slide, please. Now, how do we know if the protocol SMILE is already working? Since we are a SMILE train project, we wanted baby to smile, and that's one of it's one of the goals of SMILE train, to bring smiles back. We would want to remember the word baby, and this would be our guide to observe if relactation or if the mom supply is already back on track. First, we would want to check if baby is relaxed after the feed. It will tell us, it will show us satiety levels of the infant. As mentioned yesterday, the baby would be calm, the hands would be relaxed, okay? And that would tell us that the baby is full. Next, we would want to monitor adequate urine and stool output according to age. Now, I would often emphasize to take note of the urine because during the time of transition, when they're transitioning from formula feeding to breastfeeding, the stools might be not as frequent as it was before. We have to understand that formula milk has a different transition time or a digestion time compared to human breast milk. Formula milk takes about 4 hours to digest. Human milk can be digested within an hour. It's really important and even more valuable if during the time of relactation, the moms are supported with breast milk because the child will be more likely to feed more frequently, which in turn would stimulate the supply, law of supply and demand. But if we're using formula milk, there will be gaps in between feeding, which will affect the outcome. Okay, next, so we would like to observe the urine output. Some use disposable diapers, okay, and sometimes we just have a very little, shall I call, we want them to at least have 3 to 5 wet diapers. Disposable, I'm referring to disposable. But if we really want to monitor the intake and the output, then we tell them they need to use cloth diapers so that we are better able to see how much urine they have in a day. We would want the urine to be straw colored, not dark. Okay, usually with cloth diapers, we would see 5, 6 to 8 diaper changes. Unlike the disposable diaper we have right now, which relatively absorbs more. Of course, we would want to see stool. We would want the baby to pass stools more frequently. The stools, however, change regarding to in reference to the age. For babies 0 to 3 months, we would see 1 to 3 in a day. But as they become older, sometimes it's just once a day. That's why it's really important to take note that when we monitor stool output, we should correspond. It should be corresponding to the age. Okay, next, B, breast changes noticeable before and after the feed. We tell the moms to feel her breast. Usually before she feeds, the breast would be heavier. Okay, after the child feeds, the breast would be softer, and that also boosts the confidence of the mom that the child is able to breastfeed. Next, you would see incremental changes as to the amount of breast milk yield, which is collected through hand expression. And we see that over the course of a few days. And according to Doc Joan, it's 4 days. Earliest is around 2 days. So 2 to 4 days, you already see significant changes. Now you might ask, Have we done this to a smile trained baby? Allow me to introduce to you baby J. Next slide, please. Yeah, you see, when I met baby J, he was 28 days old and has been previously hospitalized twice due to aspiration. He is a son to a gravida tu para tu mom. She found out she had a cleft baby via ultrasound 8 weeks of her pregnancy, as reported. She had to deliver baby J via cesarean birth. At the time he was delivered, he was 3.6 kilograms. But when I met him, he was only 2.8 kilograms. Baby J has complex bilateral cleft palate, as you can see. Now, for cleft surgeries, as much as possible, we would want the lip repaired within 3 to 6 months and the palate to be repaired within 9 to 18 months. Because if the surgery is done relatively early, when they learn to speak, okay, the phonation will not be as affected and they would be able to clearly talk, okay, without difficulties with enunciation, pronunciation, and whatnot. So that is the goal that we want to achieve. So when I met them, we had to teach the mom to breastfeed. And can you please play the video? So as you can see here, despite baby J being very weak and frail at that time, when he was taken to the breast, he was more than happy to latch on and suckle on his mom's breast. Okay, so they had to do the laid back. I think that's laid back at the time because mommy's lying down on a pillow. To help them with with the weight challenges that they are already having, through the benevolence of many moms, our clinic is also one of the milk depots. We collect breast milk, which we send to PGH or Batangas Medical Center. Okay, we send this to milk banks. Okay, and through the benevolence of many moms from our local support groups, we were able to assist them with top-up feedings via donated breast milk. And the mom was also empowered to hand express as regularly as she can. When we started, she had very little breast milk. And this is the picture you see there, was taken, I think it was 4 days after her last visit, and she started to have her own breast milk. Next slide, please. Okay, so on March, we saw baby J. He gained already from 2.8. He started to gain weight. He already is 3.4 kilograms. And then April, we saw him again. He was 4 kilograms. He was gaining steadily. Although we had some challenges because he would have some health issues from time to time, which we were grateful we were able to manage. Starting July, he started complementary feeding, and it made it easier for us to manage the weight. Although he just recently had his surgery, by the way, already, as you can see in the picture, he's very, very handsome. Okay, he has had his lip repaired. It was delayed a bit because he had anemia at that time, but it was managed. Now, baby J still continues to breastfeed. He practices complementary feeding. Okay. The mom would always message me and tell me, "Mom, Doc, he always likes to breastfeed. I do not know, I do not get it." But we understand why infants are keen to take their mother's breast. First, it's the emotional connection. It's comforting. And not to mention the nutritive value and the immune support it offers the infant. It really is something. It's not just about breast milk. It's a relationship that helps both the mom and her child's well-being. So baby J has had his surgery just recently, and we are now waiting for him to meet that expected weight of at least 10 kilograms for his palate surgery to be done. Yes, baby J and his mom came a long way from struggles with hospitalization to relactation and back, and we're very happy to present baby J as the first. He was actually my first smile trying baby, and I think one of the things that made him successful, he lives from Batangas, which is quite far from where I come from. They would come. Okay, despite the challenges, they would find ways. They really kept in contact with us all the time, and we had benevolent moms who supported us with breast milk donations just to help us meet the weight requirements needed for surgery. So mommy is still breastfeeding baby J, and they are now practicing complementary feeding. So relactation is really very possible, even for a mom with a cleft baby. This is our presentation. Thank you very much for listening. I hope we have added value to your afternoon.
Thank you very much, Doc Marge. Really very inspiring stories, no, from both Doc Marge and Dr. Joanne. So maybe call back again, Dr. Joanne, so that we might be able to discuss a little bit more.
I'm back. I'm here.
So Dr. Joanne, first things first, no, congratulations on the very wonderful results of your study. No, a lot of our participants are asking where they can get a copy of your study. So the answer is?
I haven't published it yet. It was not yet published.
Maybe it's about time that you should publish it already, because it's really very helpful for all of us, no, who are working with mothers and babies, no, who really need the advice that we can get from your study. Okay, or if you want to have a larger study made, I will volunteer my hospital so that we can update your study and you finally get it published. Okay, if I may ask, what was the reason for the one mother and baby dyad who failed to relactate? Was there anything?
Yes, actually that baby is already almost 6 months old. But I also have other babies who's also almost 6 months old, but he's the only one. But actually maybe when the mother went back home, she said that she was not able to continue with her breastfeeding because of her choice, because she has six more kids to take care of. So when she went back to our 14-day and 21-day, she said that she was not able to maintain it. But actually she went back home before, like when she got discharged, she was already partially relactated, but she was not able to maintain it on the day 14 and 21. So it's still a failure, but still good.
But maybe if she was able to continue, then definitely we would see better results. No,
correct.
It's only the circumstances.
Yes, and that's what the reason why I said that when they go back to their families, there's a lot more confounding variables that will determine whether they will be successfully relactated or not. But maybe if we have shortened our monitoring, if we have shortened our monitoring or intervention, it would have been maybe 100%. But of course, we need to abide by the methodology that we came up with. So, but yes, it's really challenging when they go back home, because even the moms that were mixed fed at home, actually they were actually discharged completely relactated. However, some of them would go back to work. Some of them would go back to school, and they said that they just couldn't express while at work, even if we told them to do it. But it's actually still their determination. But that's the reason why they were tagged as partially relactated. The truth is, I followed them up maybe a year or two after the study, and some of the mixed fed were already completely breastfeeding. So, but it's really good. It's an eye opener for me, and it's really amazing. The first when I first crafted this study, I was thinking maybe the outcomes will not be good, because basing on the literatures, they said that if it took the baby 3 months, um if the baby was bottle feeding for 3 months, it will take him 3 months to relactate. And that was for almost all of the it was not true. So it was an eye opener for me.
It seems that this should be a skill that we teach all of our breastfeeding counselors in the community. This should be added to the curriculum of our courses in maternal and child care, no?
Yes, ma'am. The
Definitely.
truth
To
is,
support them when they go home.
yes, the truth is, before I left the hospital, when I graduated from training, many of them, in our hospital, in National Children's Hospital, they are the skills are there, so they have relactated maybe more. But they're not part anymore of my study. But it's when you've learned the skill, you know, it's easy to see, you can follow up the outcome, and you will be astounded by the results.
You know what stood out for me with Doc John's studies, that
Yes,
these
Marge.
kids are all sick. These infants that are included in the study were all
Because
sick.
they're in the hospital, no?
In the hospital,
Yes,
yes. And they
that's
were
right.
the oldest is 5 months old. And yet when you look at they are going back to the breast, the age didn't really matter. And most of the time you would think, if this infant is old already, perhaps it's not really feasible to relactate anymore, which probably explains why I saw one who was 10 months old already, and the mom relactated, although she only partially relactated, perhaps because at the time the child was already complementary feeding.
Yes, it's
But
more
it is still
challenging
very,
when there's
yes,
already complementary feeding, but still achievable, right, Doc Marge?
yes. That's why I was really compelled to take in and consider into my practice what Doc John has. She already paved the way for all of us. We all just need to learn from it and apply it in what we do. And now we're very, very happy to see it being applied in the context of care for cleft infants.
Right. So even for that 10-month-old, for the mother, that's already a very huge leap for her, no, to be able to achieve even just partial
And I
relaxation.
feel guilty being, I was the one who doubted, but I really felt bad. I felt guilty. I was really second guessing the mom. Is she really up for this? But I was surprised to hear from her a few weeks after that they have relactated.
That's good to know, no? And I also like, Dr. Marge, the catchwords or the acronyms that you gave us. It makes it very easy for us to remember, no? To counsel mothers if we just keep those acronyms in mind, no? Like the 4H. No?
Yeah.
It's very nice. And again, like you said, it applies to all breastfeeding mothers and babies with problems. And it goes beyond just helping the breastfeeding mothers of cleft babies. No? If I may ask, for both Doctors Joanne and Marge, is there a telltale sign or a surefire sign that this mother needs help in relactating? Or when do you say that, oh, this is just, we just need to counsel the mothers a little bit more, the milk is there? And when do you take concrete steps to do the relactation?
Doctor, would you like to answer first?
Yes, basing on my study, the relactation, there should be really two telltale signs. One of them is there's really, scanty milk supply, and the baby must be completely, bottle feeding, formula feeding at best. So it's not mixed feeding. So that's one. And the second and is the baby doesn't, you know, direct breastfeed anymore at the time of the consult. So that's when we tag for relactation. But if the baby is, mixed feeding, and when we try to like if it's face to face or even in teleconsultation, we try to tell them, "Mommy, I'm gonna teach you how to hand express." Can you, and then when I teach the moms, and then they hand express in front of me, and they will be, if hand expression is done correctly, they will be surprised at how
Yes.
much milk they have.
Yes.
So of course that's not relactation. They
Yes.
just need to be encouraged, and skills transfer is very, you know i- um is very useful. And
Yes.
if only more and more women, even health professionals, even the non-health professionals, even mothers, if the skills are transferred to them, they are empowered, you know their capacities are increased, and they will have more you know more confidence in themselves, and also more confidence in counseling other mothers. You know what, it will be better. Our cleft care, our breastfeeding care, our nutrition care in the Philippines, and even all around the world would be better. So we hope we can multiply, like for the audiences here, we hope that our skills have multiplied your knowledge, and we multiplied in you, so that you can be ready to take on those counseling.
Yes. And adding to what Doc Joanne has said, it's important to really do a history and assessment of the diet that you're seeing. We have to be able to look into the maternal history, assess the moms physically, which became very challenging for me having to do this online, but we still see quite a number who would come into the clinic because we need to do physical assessment really to be able to see their state and ask them how many diapers they have in a day, how's the weight gain. We also have to check for other impediments that might challenge the breastfeeding diet or when they relactate. We find, Doc Joanne and I, we were talking the other day, we noticed that there's quite a number of cleft babies with lip ties. And that also has to be addressed. Because it will influence the capacity of the infant to take to suckle into the mother's breast. So these are things that we need to see, but mostly we would know they're candidates for relactation after a thorough assessment and history taking, having seen how much milk they actually have. But most really, they just need empowerment, moral support.
Last resort diagnosis, no? If there are things that can be done before you reach that stage, then by all means, no, we should do it. It's good that you mentioned about assessing about other factors present. We have a question in the Q&A box. Are mothers checked for IGT? Are the babies also checked for ties?
Yes.
Okay, in my study, sorry, Dr. Marsh,
Go ahead. Go ahead.
if Miss Claire was asking about my study, well, back in 2016, tongue ties and lip ties, are not a thing, and not many are tongue tie savvy, and I was also one of them. I didn't know, but fortunately, fortunately, none of them had IGT. I knew about IGT, but none of them had IGT. Their breasts were normal looking, and they felt heavy, their breasts getting heavier and developing while they were pregnant. So there were no signs of IGT. But actually, I didn't know any better, but I actually had one who was partially relactated, but the baby has tongue tie. So, but the baby was partially relactated. She was completely relactated when she went home, and then after 14 to 21 days, partially relactated. But the baby, the mother had constant pain, and it was tongue tie. The problem is, I don't want to dwell with tongue ties because it's quite rare, but it's really important that doctors or even lactation consultants know how to look, know how to assess, and know how to say this baby needs frenotomy or this baby doesn't need. Because I've had patients who thought, Mom, Doctora, I think my baby has tongue tie because it's too painful to breastfeed. But when I check, there's no tongue tie, and I will just tell them to correct their positioning and and breastfeeding, and then they go home happy. So there.
It's
So
also
that's for
nice to
me.
mention, yeah. It's also nice to mention that not all babies with tongue ties need revision. However, it can be It can be, so the parents may choose to have it done after considering, the pros and cons. But as a clinician, we don't really release the ties if there are no indications. Okay, now going back to IGT, I think I have written a post about it on my page because I've noticed quite a few, and I'm currently doing a research on one. In terms of IGT, it's based on literature. There's 1 out of 1,000 women who have it. I guess most of the time it's not as noticed because once we see a child not gaining, the focus is towards the child and we don't really take time to look into the issues of the moms. Now, I haven't seen one cleft dyad with the mom having to deal with IGT. But let's just keep it at that IGT doesn't mean you cannot breastfeed, because I do actively manage several patients with IGT, and they are breastfeeding still. So they just need skilled help. I think it's a diversion from what we're talking about, but if at all needed, there are measures that can be implemented to help the dyad breastfeed despite the cleft and despite the IGT. Without formula feeding, yes.
It's not an absolute contraindication to
It's not.
breastfeeding.
Definitely not.
There are ways around it also. So I think that the third take-home point for today would be that we can do more and we should do more to be able to help our mothers and babies. A lot of congratulations coming in the chat box, very inspiring stories. Thank you for the very informative sessions and for sharing your precious experiences with us. They're all very thankful for having learned a lot. I think no other questions for now. Do you want to add anything more to what has already been said? We are all very grateful to have heard all your stories and your experiences.
I have a take-home message to
Yes.
our healthcare professionals. There will be mothers who will really come to you having breastfeeding issues. Some of them real, some of them perceived. But the important thing is, the important lesson is, let's not just underestimate them. We assess. We take our time to assess. We take our time to observe. And if we think that the problem is greater than what we can do, we take our time to refer. And by that we mean, by referring, we mean we know who to refer to. We refer to health professionals that we trust, and that will also listen to us as we refer. And it's very important because during the first 1,000 days of a child's life, that's the formative days, and early intervention is always key. That's it. That's all.
I think also it's important to add to what Doc J said. It's that we are part of the bigger picture when we talk of breastfeeding outcomes, not only for families with cleft, but breastfeeding is a public health issue. And sadly, sometimes our intervention only begin and end with promotion. And we fail miserably when it comes to support. And I have said in my previous discussion, it's cruel to promote breastfeeding and not support it. So I hope through this afternoon's talk, the 2-day webinar that we've had, we have planted seeds among our attendees. This is something that you can do. If you want to be trained, we would be more than willing to train you, because truth be told, we are overwhelmed with the number of cleft babies that we want to see and we want to help, but our hands are short. And when our hands are short, we need people like you who will multiply what we do, and that is our goal. And we are prayer for this webinar. Thank you so much for the opportunity to share with you the learnings and the experiences we've had, in hopes that you too follow suit and do what we do. Thank you, Smile Train. Thank you, KMI.
Again, thank you to our speakers. It is we are the ones who benefited from all the knowledge that you imparted for today, no? And we're hoping that this will just be the first of a series. It should be a continuing effort, no, for us to be able to educate all of those who are taking care of the mothers and babies. If there are no other questions, again, to all our excellent speakers, we cannot thank you enough. It's been a very eye-opening webinar. No, we only hope that we can listen to you again soon, no, to be able to learn a lot more and to be able to educate the people that we are caring for. So we would like to call back again Dr. Mian Silvestre for her wrap up of our 2-day webinar. Mian.
Good afternoon, good evening, and good morning again. Thank you, Pinky. Thank you, our speakers for this afternoon, Dr. Joanne Gallardo, Dr. Marge Sibayan, and Dr. Jessamine Saveno. I feel like my message, my recap is anticlimactic, okay? Because most of my most of what I was planning to say has already been part of the take-home messages that Dr. Pinky very, very ably moderated for the open forums of both the first 2 lectures and again this 3rd lecture. Going back just a bit, but I don't want to duplicate what they've already said, we set out to hopefully talk about cleft care and advancing nutrition in cleft care patients. But we did end up talking about basic breastfeeding counseling because we felt that what we talk about in breastfeeding counseling for all babies is the same, but especially more so for babies with clefts and their mothers and their families. No? As always, we have tried to emphasize family-centered care in all that we do. I don't want to go over the curriculum that we designed for this webinar, so I will just end maybe my recap how apropos that I'm going to end with rhetoric, okay? If that's okay with you, to end with a little rhetoric. What I think we have tried to emphasize is that the mother and the infant dyad is inviolable. They have to be taken care of together, not as a separate individuals, but as a unit or a pair or a dyad, no? And that's what we start off doing with any baby, whether the baby has congenital anomalies or not, whether the baby is preterm or full term, that the preparation of that dyad starts even preconceptionally, going into antenatal at any point of care that you might encounter these mother and infant dyads at, okay? Next, that what we have been trying to do is to, and this is maybe very overused a term, is to try to normalize breastfeeding, no? Whether under normal and as illustrated in our lectures this afternoon, under disaster contexts. We want to be able to, in disaster lingo, we call it pre-positioning, okay? We want to pre-position breastfeeding in all the communities at high rates so that we don't have to be always reactive with our disaster relief efforts because the mothers and the babies are there. The pandemic has surfaced many problems with normalization and pre-positioning of breastfeeding, but we hope that in the decade or so that has passed, since we enacted national legislation to protect, promote, and support breastfeeding, that, that the work that has been illustrated in this webinar hopefully goes from desperation to perspiration, and now the inspiration that the messages that we are trying to amplify go out. We used to say one mother baby dyad at a time, but it sounds like even in my generation, I'm so last century, but even in my generation, it looks like I might still witness the change in the paradigm so that breastfeeding becomes normal. Breastfeeding makes perfect sense, and even if you use the current lingo of sustainable development goals, the current lingo of food systems, breastfeeding will always be there. If you talk about breastfeeding in the current lingo of climate change and food systems, breastfeeding is the first food system. And like I've said in other webinars, whether for babies without or those with congenital anomalies, breastfeeding is the first food system. The mother and the newborn, mother and the infant diet should be protected just as fiercely, just as passionately as we protect our rainforests, our agricultural lands, our ancestral lands, our seas. We have to protect our first food system called breastfeeding. Thank you very much in our language. Maraming salamat po wherever you are in the world. Thank you. I'd like to turn over the floor to Ma'am Mamet Carol, the Senior Vice President and Regional Director of Smile Train Asia. Thank you very much. As always, like I said, our motto has been one mother baby diet at a time, but Smile Train has changed this for us. And hopefully with webinars like this and the multiplier effect that hopefully we inspire amongst our own colleagues here in the Philippines and across Asia and possibly even across the world, we might be able to amplify these messages even more. Thank you very much, Ma'am Mamta. Over to you.
Yeah, thank you very much, Thank you very much, Dr. Sylvester. Thank you.
Thank you too. I don't say you're welcome, I say thank you too.
Yeah, thank you for the great recap of these 2 amazing days that were especially dedicated to nutrition and breastfeeding. Thank you very much to all the panelists. So let me just begin by formally thanking you, Dr. Sylvester, for the introduction and for all the work that you and your teams do and your colleagues do at KMI. Your work has created such a huge impact on mothers and babies, especially, affected with clefts. We are so grateful for your partnership, and we know that together we can do much more for the cleft community. And thank you for all the participants for attending this important discussion on the feeding and nutrition webinar. Some of the panelists who I saw, I've been on the session last 30, 40 minutes, have been excellent, absolutely, particularly Dr. Marge, Dr. Joanne, and Dr. Lords. The lecture has been very, very inspiring, not only inspiring, but very, very informative. And thank you to all the participants for taking up the time to, come and listen to this important discussion on feeding and nutrition. Smile Train, as always, especially Smile Train Southeast Asia team led by Kimi and and June and Tompet and Tess and everyone. I think thank you to all my team at Southeast Asia. You all did a fantastic job by organizing this webinar, and all of us at Smile Train are extremely grateful for the time that all of you, the panelists and the doctors, have invested to attend this webinar. And we do hope that you will add value to to our Cleft programs. As you all know, Smile Train is committed to helping those born with a cleft as early as possible. And this webinar, I think, is the first step to enabling that Smile Train partners around the region need to provide nutrition services for those in need. Definitely, let me try, assure you that my team and I are always available. Please do not hesitate to reach out to us in terms of whether it is programs, whether it's starting nutrition programs, whether it's starting a new treatment partnership, or starting and implementing the nutrition and feeding programs in your respective region. We are there to help you. We will take you through all of that. And hopefully when the world opens up after the COVID, I would really love to see you all, especially Dr. Sylvester and your team. So hopefully either you coming down to India or somewhere in the world, or I coming to Philippines, and then definitely would like to say hello to you in person. And I was so touched by the panel discussion because, there are so many things that we take for granted, especially, us, especially breastfeeding or nutrition of mothers. Traditionally in our families, because there's so many people that you're dealing with, we take it for granted that if it's breastfeeding, it's okay. The mother will handle. So you don't need to teach them, or you don't need to tell them the right way. And sometimes in some societies, it's also a taboo. So mothers will not speak up if they are feeling they are facing a challenge breastfeeding their kids. They would not let any other person know in the family that the challenges that the mom is facing. So I think this is such an eye opener. I can't help but thank you and your team for doing the amazing work that you all are doing in the field. So thank you very much, and great thank you to my team in Southeast Asia. So thank you guys.
Thank you, Mamtaji. Thank you.
Amy, maybe we
Thank
can
you.
plug our second webinar in February.
Yes, please go ahead, Dr.
Yes, we planned for a second webinar in February, and we're going to tackle what if all this fails and the babies actually develop wasting. So our second webinar in February is entitled Screening for Acute Malnutrition. So we'd like to see you back, hopefully in February, but of course, please do tune in to the YouTube upload when Smile Train is able to do so. And I will turn over back to Kimi, I believe, for some housekeeping
Thank
work.
you. Yes.
Evaluation.
Thank you.
Thank you, Dr. Sylvester. I really look forward to the next webinar in February, and I think this is fantastic. I think Kimi will share the webinar link to all the partners who have not been able to attend today, so that they can actually watch this and guide their teams accordingly. So thanks a lot, Kimi.
Thank you very much, Mamta. Thank you for joining us, Dr. Sylvester, Dr. Sibayan, Dr. Pinky, Dr. Joanne, and Dr. Jessa. Thank you so much for sharing your time and effort and all your resources and knowledge and skills with everybody here today. We've had a fruitful 2 half days, and we are ending slightly early than we had planned. We're giving back 30 minutes of their time back to the participants. We know that this has been, a lot of time, but also that what we've learned here today is a very valuable information, and we hope that you take this all back to your hospitals, your clinics, your communities, so that we can help more infants, particularly those who are born with a cleft, to be able to feed and for the mothers to be able to nourish their children properly. So yes, just some housekeeping. All participants or all the registered participants will receive an email, which will contain links to the 2-day webinar, so you can review it again, watch it again, and you will also receive a link to an evaluation for the webinar, so we know what we could do better for the next one. So please respond to that email and answer the evaluation. And once we receive your answers to the evaluation and a post-webinar test, knowledge check test, we will give you a certificate of attendance or participation for this particular webinar. So again, thank you very much to everyone for attending. And if there's nothing else from our speakers or Dr. Silvestre, we would then say good night or good evening, good afternoon to all of you.
Can we have a photo opportunity?
Sure. Okay, Doctor.
Last request.
For all the panelists and speakers.
It's
all right.
A rare opportunity, and we also of course miss our participants from the Central Philippines that were just hit by a
strong typhoon. Yes. Mahmoud, Sabine, if you could turn on your camera too. I think I've introduced Mahmoud and Sabine yesterday, who are our colleagues in Pakistan. Ruth Mona Lisa on the screen is from India, along with Erwin. There, Erwin's there, yes.
Wonderful.
Along with Erwin.
Wonderful. Alex, Alexander, and Joanne.
Okay.
A second device of Joanne. Okay.
Yes. All right. Okay. Everybody smile. 1, 2, 3, smile. Okay. There we go. Thank you.
Thank you,
Thank you, Kimmy.
Thank
Thank
you.
you.
Bye-bye.
Thank
Thank
you.
you.
Thank you.
Thank you.
Thank you,
Nice
Thank
Dr.
to
you.
meet
Joan.
everybody.
Thank
Thank
you.
you.
Thank you.
Bye.
Thank you very much.